They could actually swallow groundnuts, and you think they are swallowing TB meds. So we need to make innovations that work for them. We need patient-centered care. And the patients for us who are adolescents, we need to understand that they're experimental, that they have a lot of peer pressure, and that, yes, we can support them to end TB in our generation. We need bold policies and supportive systems, but we also need research and innovation. At the Lung Institute, we've done various projects that are supported by the Research and Innovation Fund of Makerere University, and it includes making policies and messages that are specific for adolescents. So TB has been with us for centuries, and you've all seen these images. It starts with taking a history. It starts with making a bacteriological confirmation, and it also includes doing other investigations. By 1896, the chest X-ray was developed. We are still using a chest X-ray, but we know that there are now more advanced testing capabilities, including Gene Expert, urine lung, and others. So we know that TB starts in the lungs, but if you don't treat it, it can spread, and it can end up in the brain, it can end up in the bones, it can end up in the back. TB can become disseminated. But we need to know that not everyone who is exposed becomes infected, and that persons at risk of getting TB are those who are immunocompromised, those who get a huge load of TB, as Professor Joloba will tell you. And the infectiousness depends on whether the person is coughing, has a high load of AFBs. I won't bore you with the biology. But as we evaluate patients for TB, the history takes 70% of the diagnosis. Taking a history does not mean writing a history class. It means asking this patient, for how long have you been coughing? Who did you interact with? Do you have a fever? Are you sweating at night? And now I think some people are wondering, oh, I sweat at night because it's hot. But the sweating is involved with loss of weight and also failure to eat. Of course, these are all things that we used to do, a mantle, a chest X-ray, and then doing our sputum cultures. But the symptoms are clear. There's productive prolonged cough, although we know that this is not a specific sign or history. Some people may tell you they've coughed for a day when in fact they have TB. But if you cough up blood, then you should get worried. If you have a fever and chills that come especially in the evening, if you have night sweats and fatigue and loss of appetite, and then weight loss, which is not intentional. There are barriers to adherence, and adherence should be, for TB, 100%. The stigma is a lot, the pills are a lot, and also there's lack of knowledge of completing the TB treatment. So how can we improve adherence for adolescents who are on TB treatment? It's high time we train the school nurses, and train the school nurses, as we have done for HIV care and treatment, that adherence is at its maximum. We also need peers, adolescents who have recovered from TB, to support each other. And we must make sure that they complete their treatment. We have to meet the challenge. Of course, prevention is better than cure. And prevention starts with vaccination, like you already had. Prevention starts with giving intermittent treatment for those who may be at risk. Remember, the decision to test is a decision to treat. The moment you suspect that a patient has TB, you're also thinking that you want to start them on treatment. Please remember, an adolescent is somebody aged 10 to 19, and they contribute to over 30% of our population. Please treat them with care and make strategies that are supportive of reaching them. I want to thank you for this opportunity and also to thank you for being silent as I give this talk. Thank you very much.
Hello. Thank you, Dr. Sabrina. Can you stay for a minute, Dr. Sabrina, because I know you have an emergency to attend to. Dr. Sabrina is our esteemed pediatrician, and we are very proud of the work she does. And we are very happy she joins us in this fight for TB as she has been doing. Any one or two questions for her because she will be leaving? You can go ahead and ask the question if you have. Okay, it seems everything was very clear. But if they ask when you leave, I will bring the question. Eric will answer. Okay.
There's a question here?
Okay. So I'm sorted. Thank you very much.
There's a question here, sir.
A big round of applause.
There's a question here, sir.
Yes. Thank you very much.
Yeah.
So I would like to invite the next speaker here. Is he around? Reimagining Tuberculosis Care RCT. I don't know who is giving this presentation. Is around. This is none other than Dr. Chilis Katamba, a very well-known fighter against tuberculosis. I like him because he believes in ending TB by the year 2030. So let's see how he is reimagining tuberculosis care. Over to you, Achilles.
Yeah, just a disclaimer that the last annual meeting I said that we may not end TB, and it remained a controversial issue. I don't know whether Enid is here today, but I think now I'm going to change my tone. This time I'm coming with how do we really be able to end TB by 2030. Yeah, that's the outline of my presentation. I'm going to briefly say what is Reimagining TB initiative, what a people-centered design, how has it been implemented in Uganda and Vietnam. These are the two countries which are implementing this Reimagining TB care. We are lucky that we are one of the countries. How can the journey mapping help the country stakeholders to better understand? So I will provide some insights on how people who continue to do PCD work, how can they do it easy, and by presenting a toolkit that we have been developing as we also implement. This is work we have been doing together with the National TB Program, so it is the Walimu National TB Program doing this work jointly, and I think Dr. Stavia is one of the members who are on this team. So the Reimagining TB care is a core component of achieving the Stop TB Partnership Innovation Strategy vision of success, which involves development of new approaches and tools nurtured and promoted. So it is an approach. There may sometimes be no new tools, though we need the new tools, but how do we approach this from a community perspective? All along, many times we say the NTLP strategy is people-centered, but is it truly people-centered? To what extent are people's views being involved? People-centered innovations are rapidly developed, evaluated, and deployed. Impactful innovations are scaled up by catalytic funding. And this catalytic funding is the funding we are getting from through Stop TB Partnership at UNOPS, but funded by COICA and the USCDC. These are the two groups which are funding this project. So just why us and why us now? What we have heard from some of our country and global stakeholders and partners, we've had meetings, several meetings since January, And the TB-affected people and communities are saying we need not only be part of the discussion, but the decision-making process. The local health providers say we need digital interventions to be integrated, simple, and enable us to focus on care for TB-affected. And this really builds on, we are building also on CAST, as I will tell you. CAST is a lot paper-based, and we want to take advantage to see how to digitize some of it. Country policymaker, we need to think differently about TB care, include more stakeholders and partners, and go beyond just TB. And I think even the teams here speak to that. Minister of Gender, Local Government, Minister of what, implementing partners, civil society, and so on. Donors, current innovations that go to us here will not get us where we want to go, which is to end TB. Yeah, what makes reimagining TB care different from what value it brings? Really, reimagining TB care is to transform TB services are delivered and accessed by those. We need to rethink about how we are delivering that, and by putting in people's views. Do the people want to come to the healthcare facilities to pick their services, or what do people want? And trying to put in that. So this is really involves making the last mile, the first mile, increase and improve the provision of TB services that are more localized, closer to the people, integrated. And I heard Amanya here talk about integration, CAST integration and others. And I think this is a view we have had really, where we implemented actionable, structured, and inclusive people-centered design. We really had focus group discussions, in-depth interviews, and we interviewed a number of stakeholders, implementing partners, TB patients, TB survivors, CSOs, local leaders. We did this work in all this phase, and we synthesized that work. That work is what is taking us to phase 2. Really, what have we found out from people's needs and others? And then we need to roll out that. And this is the work that we are going to be implementing this coming year to make sure that we roll out some of those priorities, and then later on make sure that they can be integrated within our NSP and later supported by the different supporters. So our next step in 2024. So stakeholder engagements to refine the innovation proposals. What did we come out with? These are the 3 concepts that we have come up with since the work. One of the concepts is about integrated ways of accessing and developing health information. I'm sorry, before I will go back to that stage. So I think I mixed up my slides. So the opportunity areas we found during the interviews, what were the people's views? People's views were saying one of the major area gaps is about awareness. Awareness is a major gap. So stakeholders expressed strong interest in targeted outreach and education to improve TB awareness. TB awareness is a problem among the areas. The other area we found out was integrated care, which has been echoed by the CAST team and others. So even during these interviews, the communities, the peoples, and other people are saying we need to integrate care. Decentralized care is another opportunity area that we found. People want the services brought nearer to them. Resources to diagnose TB. And as we move to those communities, we need to take advantage of the resources really that can even help improve screening. There's the breathalyzer, the cough, and other aspects. How can we really bring in this? These were the opportunity areas that informed the concepts that we have come up with, which is on this previous slide. So these innovation concepts have been informed by those 4 opportunity areas we identified through the interviews. And one of the concepts we are working on is integrated ways of accessing and delivering health information. A proposal for how we can reimagine TB care in Uganda, particularly by creating tools that are available for TB-affected people. We know people in our community, some of them don't even have a phone. So if we are increasing awareness, we must see we target those people. There are those who have the basic phone, which is called the dumb phone. Also, how would you target them? There are some who have smartphones. So as we think of improving awareness, we should look at those different people. The second concept we have come up with, we are trying to work on, is digital tools to support community health workers and VHT. We've seen in CAST TB, and we are really working closely with members of the CAST TB, and other DHIS people have been major stakeholders we have involved. We have involved the people in health information system, health promotion, and the aim here is really to make sure that whatever we build is sustainable in a way, fits within that. So a proposal of how can we reimagine TB care, particularly by creating tools that are available for community health workers and village health teams to support their efforts to reach TB-affected people and the community. Community health work platform, use of technology, patient support, awareness initiative, health information booklet, efficient reporting, and that. So we've seen it is paper-based CAST. We want to see how can we digitize that component and make sure that these VHTs can have digital systems. Then the third concept looks at the leaders, decision makers, data-driven. This is a proposal of how we can reimagine TB care, particularly by creating real-time data reports and visualization for decision makers, starting with the local district supervisors up to the NTP managers. If the community health worker has got data and he's using digital tools, so this should be linked to the electronic case-based surveillance system, which is a DHIS-based system. That's why we are closely working with the DHIS2 people, the health information system, so that when you create this community system, it's linked, and even the program manager can press his button and be able to know that at least we've been able to screen so many who do this in that area. And that's the 3 concepts that we are going to be working on together to come up with what is realistic. We are going to be having several meetings with the different stakeholders so that we come up with something that finally will be funded by those funders through Stop TB Partnership, and we hope we shall start to implement this work like June next year. So this initial period is really to work on this, come up with what can be done. So there is a big team, and up there is also Mary Mbakibi, whom you will see in a video I will show shortly, Rogers Kamugisha, and many others. In addition to these are the people who have been behind the scene. Me, they just told me to come and make a presentation. So, and when the questions come up, and I think the Dr. Stavi and others will be there. So, introducing the People-Centered Design Toolkit. As I told you, as we are working on this together with the Vietnam people, supported by McKinsey and the company, which is a consultant company, has done a lot of PCD work. We've come up with a toolkit. Do the people who are going to do PCD-related work, are they going to go through this whole process? How can we make it easier? Because probably we are part of the guinea pigs, but I think we should inform. And we are coming up with a toolkit which is available online and people can access it to say, if I'm to do PCD work, what should be the process so that it doesn't appear to be real cumbersome to go through those processes. I'd like to thank COICA, Global Eradication Disease. This work is also supported by CDC through Stop TB Partnership and hosted at UNOPS in Geneva. So I will stop there, and maybe they will play more video to demonstrate this process. I'll stop there.
My name is Mpachiri Mary. I am 27 years old and I'm an MDR TB survivor. My experience as an MDR TB survivor during my treatment course was not easy. I remember my dad took me to several witch doctors. I visited shrines. Why? Because I was bedridden and very ill for a period of time, and the diagnosis was not clear for healthcare workers to come out with a conclusion that I'm a resistant patient. After being diagnosed of MDR TB, I was not able to associate with my family in the beginning. I was told to stay alone for a period of time because of the infectious disease that I had. I survived, of course, after a period of 2 years on this MDR TB treatment, and here I am. I'm now TB free, and I'm now sharing my experience with RTC project as a TB survivor.
In the face of a major challenge, Uganda's TB care services faced disruption during the COVID-19 pandemic. This led to a surge in cases. But in the spirit of innovation and resilience, a transformative project emerged called Reimagining TB Care in Uganda, or RTC. The project's core mission is to transform when, where, and how TB healthcare services are accessed and delivered in Uganda.
In the National Prevalence Survey in Uganda, they found that a number of the people who have TB actually do not have symptoms at all. 50% of the people who were identified during the National TB Prevalence Survey, they would never had any symptom at all. So they were no more walking, meaning that there is no reason for them to access services. So as you people are aware, there is always a gap between the number of cases which are notified and the number of TB cases which are estimated to be in the community. Reimagining TB care is really something that was thought out by Stop TB Partnership and partners, really to rethink the way we deliver TB care services to the people, and also the way people access those services.
The people-centered design, as we look at reimagining TB services in Uganda, is a very critical approach that we have brought on board, and thanks to our funding agencies. So really reimagining the way the service is being offered and also engaging the people in this process has been very important to enable us to do a better evidence generation.
Let's begin by understanding the heart of this initiative, the people-centered design (PCD) approach. This approach seeks to ensure that innovative solutions are tailored to the needs and preferences of all stakeholders in the TB care cascade, including patients, caregivers, and healthcare providers. This is how the RTC project employed PCD in its endeavor. It began with training people-centered trainers, including project staff and civil society organization representatives. Their mission to become the driving force of people-centered TB care.
When the RTC project was introduced to our team, we had quite a number of meetings and sessions, many of them virtual, to really try and set up the project in Uganda. And these sessions were not with the Walimu team only, because the project was being launched in 2 different countries. We had sessions where we met with our counterparts from Vietnam as well, but mostly we focused on what needs to be set up. We wanted to be sure that all the different requirements and needs at that stage are well taken care of or are projected early enough before the study was actually launched.
So the people-centered was applied right from the beginning, during the designing of the tools. So we went through a vigorous training. We had a consultant team, international team that have done a lot of people-centered work, come here and train. It was not only about training people, but it was also building their capacity to go and train other people, but to try and fully involve the people who are actually affected by this problem of TB.
They mapped the journey of TB care, identified gaps, and mobilized communities in order to foster a sense of ownership.
We went through the design of the tools, we designed them together with the people out there in the community. But even during the data collection, we employed the people to do mobilization. That is, in a way, people-centered. We used PCD still by engaging them during our synthesis process. So during the analysis, we made sure that the CSOs or the civil society organizations, the TB-affected persons get on board, and we try to make sense out of this data.
The RTs has been a very tremendous approach and the process that has highlighted different innovations that we can be applicable and tailored to the needs of the people. So we look like awareness, we came up with so many components with different approaches in awareness that can address different issues in different settings. So I think these innovations as a cascade, they're going to help achieve impact. It's a new way of approaching the TB services. It's a new way of ending TB by 2030.
The data was analyzed together with CSOs, and the results were presented involving those who participated in the immersions. 15 themes were identified, and 4 of these were selected as focus areas.
It's very important to involve stakeholders from the start, especially when you're collecting data, because they have experiences, they understand people's needs, and therefore when you're developing the tools, they will be able to bring up that experience and integrate it in the data collection tool so that you're able to get as much information as possible from the ground, and that helps you to move forward. So you don't have predetermined ideas, you don't know what you're going to get from the field, you're learning from the people that you're going to interact with.
Workshop 2 focused on prioritizing innovations. Together, they selected 1 innovation per category, ready to reshape TB care in Uganda.
We had our posters that had details of what transpired right from what problem we identified on each of the 4 focus areas, what were the solutions suggested by the different stakeholders from the field, and after going through each one of them, we again asked stakeholders to vote or to rank those innovations, and that was done online. But the results were similar to what we had got from the pre-selection meetings. We came up with 4 areas that we needed to focus on, including awareness, decentralized care, integrated care, and resources for diagnosis of TB.
As we continue to do this work, really it's going to inform the interventions. Currently, we are starting to really think about what interventions based on the needs and wants that we have gathered from the people.
As we look ahead, the journey continues. The development and rollout of these innovations are set to transform TB care, ensuring no one is left behind.
The evidence that we are going to get from this process is going to help us to frame and rephrase our next steps in terms of how we offer the service to the people of Uganda, in line with our mission to ensure that we have people access affordable quality TB and leprosy services.
This is a testament to the power of people-centered design and collective action. It is the story of how Uganda is reimagining TB care one person at a time.
Okay, thank you very much. I wasn't aware how long the video was. I was about to stop it, but when they said there is stopping TB in 2030 and patient-centered care, I became patient. So thank you very much. Dr. Chilis is our guru in operational research. I didn't want to leave anybody behind. We had two presentations which were left out yesterday. I want to give each of them 5 minutes because time is not on our side. There is a presentation on highlights from the updated National Policy on HIV, AIDS, and TB in the World of Work by Hilda Nakaga. Is she ready? Okay. Please, this is a very exciting presentation. We are at workplace, and we spend more time of our life at the workplace. So it is very important that things are taken care of at the workplace. Over to you, Hilda.
Thank you very much, Professor Joloba. Ladies and gentlemen, good afternoon. My name is Hilda Nakaga. I'm from the Ministry of Gender, Labor and Social Development. I bring apologies from the Assistant Commissioner who was supposed to give this paper. He's called Mr. Onzuma Apollo. But I'm also honored, and I believe that I'm going to do exactly what he was supposed to do. Maybe we pray a bit. I don't know whether I'm using it well. Maybe to let you know, I'm going to present on the highlights of the updated national policy on HIV and AIDS and TB in the world of work, and to also let you know that we are currently doing consultations, and your feedback will be very critical as we finalize this paper. The policy was approved by Cabinet in 2007, and mainly it was supposed to provide a framework for mounting on optimum response to HIV/AIDS in the entire Ugandan world of work. And as we all know, that a lot of challenges and changes have come up in the world, and in relation to prevention and control of HIV and AIDS, thereby necessitating its review. And the ministry, in collaboration with ILO, we did our regulatory impact assessment and a study on mapping and assessment of HIV/AIDS risks. And we came up with different stakeholder consultations, and this also included the TB integration. We have a draft in place, and maybe because we don't have much time, I would like to take you just a little bit on the statistics and to let you know that Uganda's population stands at about 42 million people. That is according to UBOS 2021. And out of 20.7 million working age population in Uganda, only about 11.7 million are in active labor force. The number of new HIV infections stands at 54,000 annually, while those whose deaths are attributable to AIDS are about 21,000. That is according to UNAIDS 2020. We have young people aged 10 to 24 years who are more vulnerable to HIV infections, with about 43% of the new infections occurring in this age group. Uganda is among the 30 high-burden TB/HIV countries. This we know, and about 1.3 million individuals in the labor force are living with HIV and AIDS. And the statistics of the men and for the women are also shown. That is according to ILO 2018. And in 2022, Uganda diagnosed about 94,000 people with TB disease. a majority of whom, 85%, belonging to the working age group. UBOS, also those are statistics from UBOS, of about 15 to 64 years. And this is still information that we know. TB still causes significant mobility and mortality, with about 91,000 Ugandans developing TB annually, including 1,500 with drug-resistant TB. And the country has also an estimated about 12,500 deaths every year. The cost of seeking care is very high, with half of the households facing such costs, and there's a decreased ability to work, either by the patients or those undergoing treatment, which lowers labor productivity. And 1 in 3 people with TB disease in Uganda is co-infected with HIV, and TB is responsible for about 30% of the deaths among the people living with HIV. And the national TB data also showed higher mortality among the TB-HIV co-infected patients, 12%, compared to HIV-negative TB patients, 7%. That is the report from NTLP 2021. And workplaces have become a key entry point of service for prevention and control of disease epidemics, including HIV and AIDS and TB, especially in managing referrals for diagnosis, treatment, and care, integration into wellness programs, and reducing stigma, among others. So we've ensured that this policy is aligned to policies and legal frameworks, and that is the UN Sustainable Development Goals, the Africa Agenda 2063, East African Community Treaty, the Constitution of Uganda, the Presidential Fast Track Initiative to End HIV and AIDS by 2030, including TB, and then the Multi-Sectoral Accountability Framework to accelerate progress to end tuberculosis by 2030. That is still MAF. And then we've also aligned to the National Employment Policy 2011, Vision 2040, the NDP3, the National Health Policy, Ministry of Health Strategic Plan 2020-2021 to 2024-2025, and then the National Strategic Plan for Tuberculosis and Leprosy Control from 2020-2021 to 2024-2025. And mainly the problem that we have is that HIV, AIDS, and TB prevention, treatment, management, care, and support services for workers in the world of work is affected by the unfavorable policies, the legal and regulatory frameworks, because of lack of integrated HIV, AIDS, and policy implementation and accountability framework in the world of work, the issue of stigma and discrimination, the inadequate access to HIV, AIDS, and TB prevention, treatment, care, and support services for the workers, inadequate budget prioritization towards HIV and AIDS, TB prevention, then the workplace-related inequalities and inequities. So there is also the costs of inadequate HIV, AIDS, and TB policy in the world of work, which definitely lead to low labor productivity. This is because these people are the affected persons. There is a sustained increase in absenteeism related to the impacts of the disease. And then there is also poor quality of life as a result of sustained vulnerability to the impacts of HIV and AIDS and TB. Then they also don't take their medication. And then there is social support and protection services, increased mortality and morbidity rates. And then we also have slow economic growth and development. That is as a result of low contribution of the GDP due to the low labor productivity. Our goal is to realize a favorable policy, legal and regulatory framework for the effective and efficient provision and access to HIV and AIDS and TB prevention, treatment, management, care, and support services for in the world of work. These are the objectives of the policy: to integrate TB into the HIV and AIDS policy implementation and accountability framework in the world of work, to eliminate stigma and discrimination related to HIV and AIDS, TB in the world of work, to improve access to HIV and AIDS and TB prevention, treatment, care, and support services for workers and the community, to prioritize budgets for HIV, AIDS, and TB in the world of work, and to also address workplace-related inequalities and inequities. Implementation of the policy is expected to yield the following outcomes: reduced mortality and morbidity related to HIV and AIDS and TB among the working population or the labor force, and then increased productivity in the world of work, increased access to HIV, AIDS, and TB prevention, treatment, management, care, and support services, decent work for all in the world of work, accelerated and inclusive economic growth and development, improved quality of life, and increased household income and well-being. And these are the strategic interventions. We want to integrate TB into the HIV and AIDS policy implementation and accountability framework in the world of work. We want to operationalize mechanisms to eliminate stigma and discrimination related to HIV and AIDS and TB in the world of work. Then we also want to enhance efforts to improve access to HIV and AIDS and TB prevention, treatment, care, and support services for workers. We also want to prioritize budgets for HIV and AIDS and TB in the world of work. Then implement mechanisms to address workplace-related inequalities and inequities. So the Ministry of Gender, Labour and Social Development will take lead in implementing this policy through our tripartite plus, that is the workers, the government, and the employers' organizations. Then a national technical working group will also oversee the implementation of the policy, and each ministry, department, and agencies, including local governments, has a role to play in policy implementation based on their mandates in HIV, AIDS, and TB prevention and control. Then contributions are expected to come from the government of Uganda, development partners, non-state actors, social partners, including the private sector, civil society, families, and individuals. All of us are in this room. And then the Ministry of Gender shall also continue to work with the HIV and AIDS and TB actors and other stakeholders on the already established management information system within the ministries, like Ministry of Health, and shall develop key performance indicators on HIV and TB at the world of work.
Thank you. Thank you very much. It is reassuring to know that our Ministry of Gender is thinking about us, the people in the formal sector and probably the informal sector. Thank you very much. Another big round of applause. I think then the second last presentation from Mr. Tahinduka Francis, leveraging existing social protection programs to enhance TB care. I think this one will do it in 2 minutes. Or is not available.
Pardon?
Are you the presenter?
Yes, I am.
Okay. You said in 2 minutes, not?
2 minutes?
Okay.
Thank you very much. Good afternoon, ladies and gentlemen. I'm given 2 minutes, and I want to devise a mechanism of working in 2 minutes multiplied by 5. My name is Tahinduka Francis, as has been mentioned. I work with the expanding social protection program of Ministry of Gender, Labour and Social Development. I want to start with a simple story, which will take a very short time, of a person I knew called Yakobo. Yakobo is not his real name. This Yakobo was a border rider. He joined this trade of riding border after dropping out of school in Form 3, when his widowed mother was not able to support his school fees. A neighbor leased him a motorcycle at 20,000 per day. 2 years down the road, Yakobo took a decision to sell part of the land that he bequeathed from the late father. At that time, he was cohabiting with a girl who dropped out of school in P7 at PRE. But then they migrated to Kampala, where he rented a one-roomed house, and they started riding his motorcycle from there. In 4 years, Yakobo had 3 children, but he started falling sick, wasting away, coughing, and eventually he claimed he did not have money for treatment, but he would go to drug shops and get some little treatment, but he did not respond. Eventually, he was advised to go to a government facility. In a government facility, he was diagnosed with TB, and it was in advanced stages. He was admitted for a period of time. On his discharge, he reached home. He found an eviction notice from that single rented house. Eviction notice was on the table. Children, of course, did not have what to eat. So, Yakobo, looking at what was happening around, he decided to encourage himself. He went to the landlord and negotiated payment. He started sneaking out to work to be able to fend for his family. And on a fateful day, when Yakobo was at the stage, he collapsed, he vomited blood, and then he packed. That was an unfortunate event that happened in Yakobo's life. But there is a story to tell. There is something that we learn from Yakobo's predicament. These are questions for reflection. Who is accountable for Yakobo's life and predicament? Did Yakobo expose more people to danger of TB before he was diagnosed and even after, because he continued sneaking out to fend for his family? What risks exposed Yakobo to this predicament? What will happen to Yakobo's family? He has a widowed mother. He left behind a widow and 5 children to be taken care of. What can be done to help many Yakobos that we have in this country? There are so many Yakobos in different trades. Don't look at only Yakobo, a border rider. What can be done? And whose responsibility is this? Ladies and gentlemen, I will need support. IT, it is not moving at the pace I expected. We want to look at leveraging on existing social protection programs to enhance TB care. The story we have just listened to summarizes why the government of Uganda undertook to implement social protection programs in the country. As a matter of outline, we wanted to look at the social protection context in the country. We wanted to understand vulnerability, like the Yakobo was. We want to understand what social protection is about. Then we shall look at and how we can leverage on them to improve TB treatment and care. You may all be aware, we have Vision 2040, we have NDP 3. They all recognize social protection as an important national development strategy, and government of Uganda spearheads that strategy to address risks and vulnerabilities, to fight poverty, to reduce inequality, and to promote inclusive economic growth. The main purpose of social protection really is to enhance resilience and productive capacity of these vulnerable groups. For purposes of definition, in Uganda's context, we know social protection to be public and private interventions that address risks and vulnerabilities which expose individuals to income insecurity and social deprivation, and of course leads to undignified lives. Social protection has two pillars. We have social security, and we have social care and support services. Under social security, we have two subcomponents. We have direct income support. We also have contributory social protection. Under direct income support, we have cash transfers, we have labor-intensive fabric works, and many others. Then contributory, a good example is National Social Security Fund and maybe health insurance. But in the implementation of social protection policy, all of us in this room are part and parcel. We are all involved at different levels. Social care and support services target those individuals that cannot fully care for themselves. Under that, we have child protection, we have support of victims of GBV, we have rehabilitation of services for the youth, rehabilitation services for people with disabilities, and then support for older persons. Vulnerabilities. I may not need to repeat this. I used the story to make us understand the vulnerabilities that individuals are exposed to. Those vulnerabilities affect their ability to cope with different shocks. In terms of TB management and care, in this country, I came to learn that we have one social protection program that targets specifically people with TB and is implemented by Ministry of Health. But otherwise, we do not have a comprehensive social protection program that targets specifically and categorically TB patients. But anyhow, we can still think through how can we easily target TB patients? How can we also integrate them in the existing programs? In our slogan of leaving no one behind, when we are implementing social protection, we still have various interventions which TB and affected households can leverage on. Currently, Ministry of Gender is developing various frameworks for social protection. We are developing National Social Protection Strategy. We are developing shock-responsive social protection framework. We are also developing operational framework for social care and support systems. We look forward to participation of all stakeholders to give us ideas and to make sure that TB services are also integrated in our frameworks. Ministry of Gender has been working closely with the Ministry of Health to work on health insurance. With health insurance, the concerns of Ministry of Gender are that it should not only focus on health financing. If the focus is mainly on health financing, we shall only target people who have finances, and then we shall leave out vulnerable groups. And this is the reason why it was bounced back. We need to make sure that all the vulnerable individuals are part and parcel of health insurance system. And this health insurance should promote universal access to health. If, for instance, Yakobo had was a beneficiary of insurance, of health insurance, he would have been diagnosed earlier, he would have been treated earlier, and we would not have lost him. And then vulnerabilities and social protection arena, we want to address vulnerabilities across life cycle. And in this regard, we have interventions for pregnant mothers and lactating mothers. We have interventions for children. We have interventions for youth, for working groups, and for the elderly, for the older persons. In all these interventions, the target is to build their resilience. And in implementing these interventions, we want to implore everyone that support us. We need to integrate different services. In West Nile, we are Ministry of Gender, OPM, and World Food Program are implementing NutriCash. This NutriCash, we can borrow an example from it. It has integrated services. On a payday, when beneficiaries of NutriCash gather, health centers organize health camps. Immunization takes place, awareness creation takes place, and many other services in one day. But also the design, we can also leverage on the design of programs. NutriCash is designed in such a way that it does not only look at the financial component, it also looks at nutrition. It also looks at market linkages. Can people access nutritious food? Can people have backyard gardening and produce their own food and be able to address the issues of nutrition? Integration of services is emphasized here. Likewise, I want to bring to your attention that Ministry of Gender with the Roharo Mission Hospital, supported by Fred Horo Foundation and CBM. We are partnering in implementation of SAGE. The role of Roharo Mission Hospital, they are piloting a program for health aging, where they come and assess and screen our older persons. Not only for TB, not only their entry point is eyesight, but now they have extended services to look at all the health issues of this older person and then refer them to where they can get services. We need more partners to partner with in this area. Under NSSF, you're aware NSSF has different products. One of the products is for people who are terminally ill. If you are a saver and you are terminally ill, you can access your savings before the mandatory age of retirement. But still, under NSSF, we have midterm access. This releases funds for those who need funds, who would otherwise fall off from our baseline for social protection. They also have a product of voluntary savings. So people can save when they are still active. They can save when they are still working and strong. If my friend Jacobo was saving, had a voluntary saving somewhere, probably he wouldn't have waited until he reached that point of being so weak. Jacobo would have withdrawn his savings, and he would have accessed treatment in time. I have talked about existing opportunities in the design of programs, and you are aware COVID-19 was an eye-opener to all of us. It helped us to understand that we need to be responsive in most of our programs. And in that case, you will hear of, we had a program called Urban Cash for Work. It was added to other programs under labor-intensive public works to respond to those vulnerabilities that were emerging from COVID. I really think I exhausted those issues. I want to thank you very much for listening to me.
Very much, Francis. You realized I left you to multiply your 2 minutes because I do believe in social protection, and I think it's a big part of what we have to do to end TB. Yes. So thank you very much, and for that guidance. We have been, colleagues, we have been joined by Mary Bogman, a PEPFAR coordinator of the U.S. mission in Uganda. Mary, you should know that throughout the conference, when you were not here, people were very appreciative of the contribution of PEPFAR and U.S. mission. Thank you very much for joining us. Thank you. I'm the next presenter. I am the chair. I'm also representing the commissioner of laboratories. But I really want to put off some of the, I want Raymond to at least regulate me. I know all power is very good, but let me say, it's not very good to have too much power. So, okay, colleagues, I really know we are coming to the end and we are close to lunch, but I'm very happy I will be very fast to take care of this. My slides are up, and my work has been made very easy. People have emphasized the importance of diagnosis across this conference, and people have also emphasized that a lot of resources are needed to really detect TB patients, and actually it's one of the biggest contributor of the catastrophic cost. Francis, really thank you for that story about Jacob, and there is a lot of resources which took in to really have Jacob diagnosed. I might have to say some prayers, I think, also. I wish I had not given up some of my powers. I would. Okay. Do you need help from me? think we are sorted. I don't have to repeat this, that TB is a leading cause of death, and TB patients in many countries are facing catastrophic cost. You had the story of Jacob. And again, the map demonstrates it that much as the sub-Saharan African countries here have made much progress in the reduction of incidence, we're still a very high incidence continent. And, okay, that is the case fatality ratio, in the meaning that the people we diagnose also die within care because we diagnose them late, and sometimes we don't have universal DST, and we put people in inappropriate regimen, the resistant people, giving them susceptible treatment. And this is the catastrophic cost. If your eyes are very good, on the left here where things are blue is the catastrophic cost for drug-sensitive TB, and on the right is catastrophic cost for drug-resistant TB. And if you can locate Uganda, Uganda exists in both these. And that's why I was very sympathetic for the catastrophe, for the social protection. And for the people with drug resistance, it's even worse. It's about 100%. So I know we have seen this graph, but I would really want to re-emphasize it, that part of it, when you see that dotted red line, that if we do nothing, actually TB will reduce and maybe also end, but close over 100 years. If we do optimize what we have, including social protection, universal health coverage, we will go to that second line, and it will take another 50 years or more to do that. And then lastly, that we need to introduce new tools and innovate. And probably this point of care test is very important for us to really end TB as the end TB strategy. In Uganda, and many times people don't think that they need to optimize and they need to innovate. But throughout this conference, it has been very obvious that in Uganda there has been a lot of optimization, a lot of innovation, and you have brought on board people from the social protection angle and the workplace, which I think embraces these three targets here: reducing incidence by 95%, mortality by 95, incidence 90, and catastrophic cost to 0. These days, I give presents, and it's part of my examination for students who remember 95%, 90, and 0. 95, 90, and 0, they get a bonus and sometimes a reward. Thank you for this conference. If there is anything you go away with, please remember 95, 90, and 0. I think the person giving coupon for lunch, can we really see if a person can't remember these three figures, should be denied a coupon today. So thank you very much. Okay, in addition to those, the global targets, this one I will not elaborate. The national program of Uganda has developed these 6 strategic objectives, and they have been mentioned over and over again. But let me zero down to TB diagnostics. And let me remind you, colleagues, TB is not a new disease. Don't you think about COVID. TB is over 1 million years, and they have found TB in the mummies, and as long as human beings were living, TB has been there. So it's been with us. In 2010, I was invited to give a talk, recent advances in TB microbiology in Uganda. And I went and gave that talk. When I was invited to give the talk this time, I went back and looked at the presentation I made in 2010. And I will share, I wish I had the time to share with you the whole presentation, but I will share you a few slides which I gave in 2010. In 2010, I said that the microscope here, the monocular microscope, discovered in 1882, used by Robert Koch, had been used to diagnose TB for more than 100 years. This is the only tool which was very predominant and being used to diagnose TB. And when we entered the field, this was the main tool which we were using. And in 2008, an LED microscope was introduced. So tools in terms of diagnosis are not very old. They are very recent. But how has this field developed? So I made a presentation then that Uganda had 80% binocular microscopes in 2010, and we still had 20% monocular microscope. And our plan was to eliminate monocular microscope. Those were our plans then. And we wanted to introduce LED microscope in busy units. That was our presentation in 2010. And we wanted to introduce external quality assurance to make sure microscopy at least covers 90%. And we are changing a diagnostic policy from 2 smears to 3 and 1 positive smear instead of 2. Unfortunately, many parts of Africa are still at this level. But Uganda has made some tremendous progress, as I will show you. In 2010, we had it, before 2006, we had 2 culture labs. And at that time, we were having 8 labs which are joining culture. And the plan was to introduce more 7 culture labs in the country. This was my presentation in 2010. Now, at this time, we are looking at NTLP in 2030, and we have more tools. And we are talking about increasing access to rapid and accurate detection of TB, and make sure everybody gets a DST, and make sure that our services are of quality. These are our 3 key objectives. And there are many 12 indicators here. I'm not going to bother you with them, but I will need to draw to your attention indicator number 4, which is actually increasing connectivity and IT solutions into care. And I think it has been mentioned. And the last indicator here, number 12, which is ensuring accreditation of our laboratories. So, okay. And the WHO has recommended various techniques for diagnosis of TB, from microscopy, molecular, culture, susceptibility, and immunochromatography tests. Clearly, the WHO, this highlighted molecular WHO recommended diagnostics, argues that we need to use that as the initial test, such as EXPERT, TrueNAT, LAMP, sequencing, and LPA, and many of these have been mentioned. The other ones are also recommended, but we need to use that molecular WHO recommended list for initial diagnosis. So I hope that has already been emphasized in this conference. And other important tests, such as HIV test and chest X-ray, have been emphasized. But I want to draw to your attention. In 100 years, we had 1 tool. But now this pipeline is very rich. Actually, after 2010, when I made my presentation, you see we got a cartridge, GeneXpert. We get a TB LAM in 2012, 2015. 2016, we get line probe assays. 2017, we come to add Ultra 20 and LAMP. And 2019, we're going for stool for TB. And by 2020, we do have XDR cartridge. We do bring in TrueNAT. 2022, we do have a computerized aided digital X-rays. We have been talked about. Somebody talked about sequencing. Yes, 2023 here, sequencing has been added. But we really still, the pipeline is still going. In 2024, we are looking at having more tests coming in. Can we use other samples other than sputum? can we sample others? So we can't, and we are even looking ahead of 2025. So colleagues, I think in this generation, we really have the tools. People did control TB with that one monocular microscope, but we have this arsenal of various tools in our hand to use. So there are other diagnoses which are coming in, non-sputum, host-based biomarkers, bringing in artificial intelligence approaches. All are tools which are upcoming to control TB. So we can't say we are not well aided. In Uganda, just, I think many have been mentioned. I will just take you briefly what we have here among those tools, and I can assure you we nearly have everything mentioned there. Microscopy still exists, GeneXpert, we have 320 platforms, TrueNight in 40 sites, TB Lamp in 17, lateral flow lamp in more than 1,000 sites, IGRA for latent TB in 6 sites. We have 2 public TB reference laboratories where culture can be done, and I will tell you that culture is still very relevant. As you will see, we have research laboratories really to do innovations and optimization. We have an integrated sample referral system for access to care and a connectivity solution, which actually is aided a lot, improved in terms of transmission of data, collection of data, and analysis. This is the GeneXpert map, and you could see it's distributed across the country, but actually as this conference was emphasized access to care, catastrophic cost, the number of these machines are not adequate to achieve what we want for TB, HIV, early infant diagnosis, and other diseases, as you could see, which are being done on this machine, which is a multi-disease platform, which is already overwhelmed. We need more for us to really achieve our NTB strategy. We have a simple one-step tool for TB in children, and over 75 now GeneXpert machines are already able to do testing stool from children. Here, pediatricians had no solution. The other tests were very aggressive. So we have a solution, and they're actually able to diagnose drug resistance in children, which was very difficult before. And we have an XDR assay. I can tell you this is a dream come true, because at least you had to send for second-line drug DST to the National Reference Laboratory for culture and DST. But now, soon after rifampicin resistance is detected, you are able to test for other drugs, isoniazid, ethambutol, fluoroquinolone, and second-line injectables. Some of these are not being used, but results are available, and more cartridges are on the pipeline, as I showed you, which will make this much easier. We have a TrueNight with a portable battery-operated device, which helps where electricity is a problem and requires minimum infrastructure, can room temperature stable, and really can add to increase the detection of TB. So it's already, as I showed, 40 of them are here, and we hope to get more. The TB lamp has also been mentioned, the loop-mediated isothermal amplification, and it really works at 1 temperature. You just need to warm up that block, and you don't have to change temperatures, and it really can do many. But remember, lamp doesn't give you a DST. If you get positive, you send where there is a rapid solution for that. This one has been mentioned, the community TB laboratory services, and I'm happy it's already going where there are hotspots, and in there is a WHO recommended test, GeneXpert, and other tests, which actually gets access. In terms of prevention, latent TB, we look at antigens and also IGRA for plasma, and that is already available in Uganda, as already said. we can only expand more to really, if we can really get our targets. And the sites where there is IGRA mentioned here, in CPHL, Soroti, Arua, Hoima, and Imbarara, and other antigen tests have been earmarked for that, not yet on the market. Hopefully, they will come if we intensify in that direction. I talk about MKIT drug-associated testing. Much as I've mentioned many of those pipelines, remember some of the new drugs are coming on the market and we don't have molecular markers for them, and we still have to use conventional methods. One of these methods shown here is actually a modification from South Korea of LG. And just briefly, you can test 16 drugs at once, and you will be able actually to get results for particularly focusing on the new drugs. And we have a broad microdilution drug-associated testing, and you may not be aware, they talked about BPAL-M here. New drugs are coming on, and they are not available in other methods. Uganda is ready for that. We do have here microdilution media plates. This is the method, and we can able to give you DST for these new drugs: bedaquiline, delaminid, fluoroquinolones, linozolid, chlorphazimine, and cycloserine. So please, we are ready. So I liked the talk about patient-centered. In other words, we want to bring things, quality services to here. With the green arrow here shows movement of either samples or patients to a testing facility, and the red one is movement of the results, which is quality assured to the patient. In Uganda, you know, we have the hub system, and samples move to the hub, where all the hubs actually have a WHO recommended diagnostic test, and if they require further testing, samples are moved to the reference lab. And so these are the 100 hubs in the country, which really helps in the referral system. But we are not settled. We need to innovate and having more optimization of what we do. We have finished a pilot here. If you observe here, there are two models here. The one is called the Muvule model, and the other one is called the Uber model. I don't know why I didn't like what the Muvule, they should have said the Kayembe, because I believe there are more mango trees around the health facilities than Muvule. We have cut them. But that means that near every health facility there is a border stage. You could really train these people to deliver samples to the testing facility in real time, because they are available all the time. And then there is a Uber, which operates in some of the city here. It's a call away, and this could really respond in real time. So these two models have been evaluated, and I can tell you they can deliver a sample to the lab in less than an hour. In a matter of minutes, the results will be there. So you could see there is a solution to that green. What about the red curve? How do results get back to the patient and the health care provider? A connectivity solution has been pioneered by Uganda and really already embraced, in that meaning it extracts data from the machine in real time and gives feedback to the clinician and the patient in real time. I'm talking about in terms of, I don't know whether microsecond is the right measure or nanosecond. Results will be already gone. And so it helps in supporting gene expert, monitors utilization, equipment functionality, inventory management, linkage to patient care. So the other time I said I'm no longer very popular to my program manager. She used to call me to ask me results, but now she has results on our app, so she doesn't need to call me. So anyway, these machines are directly connected to this connectivity solution, Expert, TrueNut, X-ray, right in real time, and integrating other diseases, TB, HIV, COVID, HPV, and more are coming on board. And nearly all gene expert machines are covered. 37 of 40 TrueNuts are covered. And so, as I've said, these are only on the machine. So we look at the machine, look at MDR linkage, utilization rate and errors, and how modules per module are functioning. So in other words, I have seen a revolution. Actually, the delay in lab testing is within the lab. It's possible to have samples delivered in hours and results taken back in a matter of nanoseconds. So when they say the point of care is needed, I think the lab is really delaying the patient. The other areas can be really figured out in time. So I think these lessons from Uganda has not been selfish. We have supported these countries, about 21 of them, from 2015 in sub-Saharan Africa, and one here in West Africa. And we have really, from 2015, this is how this map looked like. The red were the worst performing. There were 2 accredited countries in green. So you can see this color coding. 3 years later, that's how the map looked. And another 3 years, that's 2021. That's how that map, and I think you could see that we had more greens as we go along. And as we stand today, this is how the map looks. We have been added more countries, and it's really improved as SRL. I think I need to end, and I agree that we can win this fight. It's a longer fight, but we are marathon runners. We can win the battle. And I believe we are all convinced and on board. Thank you very much. So I think my presenters, I really like the people from social protection and the work. I wish we can really ask most of the questions in that direction. I'm sorry, Dr. Katamba, but these are very, so please, social protection ministry works. I think I will only prioritize these ones first.
Here. Yes, thank you, Prof, and thank you, our dear presenters. I also liked the presentations from Labor, Gender, and Social Development. I think I've not been asking questions since we started, but they intrigued my my thoughts. Yesterday we signed the commitment. Mary, you are not here. I will request that you append your signature there on that board to show the commitment from PEPFAR to end the suffering for our people living with HIV. One of the commitments was to achieve 100% health and social protection for TB patients. And Francis, you really have given us a number of opportunities. I would like that from you and also from colleagues in this meeting, how do we make these opportunities a reality so that in 2027 we can say Uganda actually provided social protection to TB patients? I know health, you talked about the health insurance, and we'll continue to push for that. So I want the practical ways. Yes, there is midterm access for NSSF. What is it that we are going to put in this guideline for midterm access to favor the person who is affected by TB?
and many others that you presented. I think when we answer that one, I will be very happy, so that we work with you to realize that at the end of the day. Then for you, Hilda, yes, thank you for pushing this policy. We are very excited to have it out. TB prevention at the workspace is very critical for us. It will enable us achieve some of the other targets that we signed for prevention and for also accessing the care, universal access. So I saw the goal. I thought we would add their quality in that goal. You needed input. I think it is important that we see how to squeeze the word quality there. Thank you.
Yeah, thank you so much. The presenters, let me stand up. It's good practice to relax a bit when you get a mic. Nkolo Ebo, I work with URC. I said it's based in Maryland, but I'm based in Uganda here, and we have two projects that are running, UHA and DOD. I know DOD touches TB, and UHA is about to touch TB, but touches indirectly by strengthening the systems. Now, the presenters, social protection. Our thinking about catastrophic costs, and Moses said, Professor Jolova, that we should always remember the three things. No lunch if you don't remember, at least I remember the last one, that catastrophic costs should be zero. How are we going to measure this versus social protection? I know there was a study done some 2-3, is it 2-3 or 5? 2018, yeah. And that study showed us the catastrophic costs were around 53%, I think, for MDR-TB. How do we change that indicator? The indicator stayed stagnant. If you recall the slides that were showed, it has remained constant. I'm going to the second question. So how do we measure that, and how do we do that? And the second question is on patient-centered design or patient-centered approach. Also versus patient-centered approach, if you look at catastrophic costs, are we moving? Patient-centered approach, what is it? We talked about indicators yesterday, about them, are we touching the patient? Is the patient saying, I'm receiving the TB service 100%? Or if we were at 20%, does the patient say that you have done everything, now we are moving? I know the study touched that, but what else do we need to do, and how do we need to do that? The patient-centered approach, I know even the program manager presented the 5 years of patient-centered approach. But what is this path? What are the tangibles around as we move around? Then lastly, microscopy. I think microscopy, the way we talk about the microscope will be thrown out of the lab. And I know yet we need it for monitoring. I don't know whether I've been out of TB for about 1 year. Has it been thrown out for monitoring TB patients for 2? It used to be 2, 5 and 6, something like that. Those are my questions. Thank you.
I think let's get to that question there, and then we can respond.
Thank you, the presenters and chair, for giving me this opportunity. My name is Edwin Wajira. I'm a physician, and I take care of adult TB patients at Mbara Regional Referral Hospital. I'll start with you, chair, because you are also a presenter. Please enlighten us what catastrophic costs are. Because as long as we don't have a national insurance scheme, we are all victims. And then to the presenters from Ministry of Gender, you talked about the social protection mechanisms. And I know Dr. Nkolo has asked about this. Other than, an insurance scheme, Are these other mechanisms really evidence-based? Are they sustainable? Because if you hand over cash, there are many other things that are going to take the cash before it does what it's supposed to do. At some point when we have the cash, we'd rather settle other social things before we even talk about health. And about integration of, services within TB care. On the slides, there was something to do with NCDs, mental health, diabetes, hypertension.
Be attentive, you are going to be protected.
Thank you very much for those comments. Many of them, to have a change in health-seeking behaviors, then we need mindset change. Yes, we have talked a lot of science here. Science will not stand alone without the social science. Otherwise, science will do the good job and it will remain in the shelves. They need the sensitization, they need the mindset change, they need awareness, and these are some of the things that we can add into what we are doing to be able to kick out TB. About social protection mechanisms being sustainable, reference is made to cash transfers. There has been a lot of research done on cash transfers. Personally, when I first heard about SAGE, that they are giving 25,000 to an individual per month to survive on, to improve lives, I first sat down and laughed. Not until I practically saw it happen that somebody can get 20,000 and they buy goats, they buy chicken, they buy cows, they invest in the productive ventures, and their lives have changed over time. It has not only affected the lives of these particular individuals, it has affected lives of their neighbors. It has ensured employment. It has ensured economic growth of this country. So that's small cash transfer sustained. We hope it will transform the economy. Thank you.
Yes. Welcome. I really want to invite Dr. Paul Isiko to come over and take over from me. But Achilles, you are welcome to answer your question. You will also answer the catastrophic cost, because I cannot do it when you are around. You are the
okay.
guru. Yes.
Okay. Yeah. So, hello. Yeah. So I have the social protection issue here, especially the catastrophic cost. Probably the doctor said the national health insurance, the national insurance which is coming, and I think we've tried to analyze the social protection sector in Uganda, working with Ministry of Gender. And it's very clear that even when the national health insurance is in place, it will not fully address the catastrophic costs. It's probably going to cover the out-of-pocket expenses for everything. Through a survey we did recently, and we looked at the currently existing social protection through Ministry of Gender and local government, they are all TB sensitive, which are in Ministry of Gender and local government. If you are someone 80 years and above and you get TB, you will qualify for surge. But does surge, even when you qualify at the 25,000, could it cover all the costs that you incur when you have a TB episode? Probably not. So they are TB sensitive, most of them. There is only one TB specific social protection network, which is supported through Global Fund, TASO, implementing it, the Enablers program for people with MDR TB. And I think the recommendation here, if we are to address the catastrophic cost for TB, is to come up with a TB sensitive social protection for patients with drug-sensitive TB. And probably that would be the way to address catastrophic costs for TB. So for that, I think I will go back to Ebo's issue. that when we finally do this people-centered, will we be able, how will we know that actually we have addressed the needs of the people? I think the needs of the people probably may not go through the interview. However, we have said that 30% of the TB patients are never come to the healthcare facilities. We know that people only come to see clinicians when they have pain. People are moving with their masses, with their swellings every day, but until they have pain, people 50% don't have symptoms. So we have people who are in the community there, unless we take services to the community. And I think the way we shall measure impact will be that if we have decentralized services, as people have said, we have integrated services and carried out awareness, we should see that our notifications are in line with the incidence or the estimated cases. And that way we shall see impact of our services. And I think in a way it will reduce catastrophic costs, because why do as a patient have to come every day to pick medicine from the facility? Is there people who could pick the drugs within their vicinity from a drug shop or any other sort of a differentiated service delivery model and others? Probably it will reduce the cost people spend, and in that way reducing catastrophic costs.
Okay, I think Paul is close. My question is from Ebo, and it's really a hard question. I'm going to answer it with my two hats. The first hat, I'm going to put on the program hat and tell you that please do microscopy for monitoring patients at your 2 months and at the end of therapy. It's very relevant, because if it is still positive, it will tell you something. And then I will remove that hat and put on another hat and tell you that much as we tell you to do that, it leaves a lot to be desired, because most of the patients are coming in when they are smear negative, and microscopy funding is getting limited, and so that, I think if you are paying attention, I told you that we needed to innovate, bring new solutions. And the pipeline is not empty. I think there is a move to have other tests for monitoring for treatment, which are in the pipeline. But for now, do the microscopy. Thank you very much. Not on our side. I really want to hand over this to my another burning one. Okay, let's get two burning ones. Okay, as the chair you come, let's get these two burning questions and end this.
Chair, thank you. It would have been an injustice, really, because you didn't see my hand. My concern here is very key, and it goes to Dr. Katamba. Looking at his presentation, he really started well, saying the community should be included in the participation and the decision making. Looking at the strategy they are coming out with, I'm looking at an imbalance, because in the TB, we have got critical key and priority populations. This includes refugees, prisoners, the fishing community as the third vulnerable, according to the recent study which the M&E presented recently. And we have people living with HIV. And my sister here presented about adolescent girls and young people. What is the composition of your civil society engagement? Because I really understand there is no single individual which can represent the civil society. It is a multi-sectoral approach, and that's how HIV has managed to reach community. This is very important because we have national networks, we have regional networks, and the district level. Secondly, we also have innovations to leverage on these constituencies which are priority populations. For example, we have got the peer approach model. For those vulnerable group, we have TB survivors who are very critical to support these engagements and policies we come with. Even creating policies, we cannot put them forward minus engaging these communities, because it will be hard for you to implement when they are not part of the processes. And with that, I just want to thank the chair has been fair to me, so that my burning issue has come out. Thank you.
Looks like the new chair is not. There are some two burning questions here. Yeah, since the chair has not overthrown
the microphone.
You
the
microphone. Take your seat, chair. Take the other seat. Otherwise, I'm conflicted. So there are two questions there. Where is the mic?
This chair.
There. Yes. Is Dr. Seyum? Or you were pointing to? Oh.
Thank you,
Chair. My mic. Okay.
I'm Padeb Surwa, Uganda Stop Tea Partnership. Chair, I'd like to say also thank you to the organizers of this very important conference. And it's unfortunate that we have not had enough time, because I think I've been advised that for some of the presentations that would have been made, we just have to summarize them now because of time. But we are supposed to have one from civil society on resource mobilization for TB. And I was supposed to make that presentation. Just briefly, I wanted to say that the resources for TB, when we talk about resources, normally think about the dollar or the shilling. The perception was going to be very, very different. And want to talk about things like a human resource for TB, what do we have in the country, presence of policies, plans, commitments for fighting TB, the infrastructure, the different types of infrastructure, equipment building, engagement of stakeholders, effective engagement of stakeholders as a resource in mobilizing TB, TB fight. Then provision is for integration as one of the resources. Chair, also, lastly, political will. We are talking about how much money has been allocated. But lastly, also, rational utilization of the above resources as a resource for fighting TB. That's what I want to talk about as civil society. But now we thank you, because some of these things have been highlighted here and there, and we all recognize that we don't have probably enough resources for TB. And yesterday I learned to stop agonizing and start getting organized. And we therefore need to get more on that line of getting ourselves, because actually we do have some resources around us. Policies are resources, commitments are resources, strategies are resources, as I've just put in that concept. Now, lastly, Chair, just wanted to know what is expected of civil society in fighting TB in the country, because as far as that important arm also, and the reverse we have, probably if we can hear some voices of the expectations from civil society as we wrap up this very, very important conference. Thank you very much. Over.
One more hand here, and we come close. Please, everybody must answer the civil society.
Thank you for this opportunity to thank Dr. Katamba. Moses Arinitwe, Learning and Knowledge Management Research Coordinator at NTLP. In talking about reimagining TB, I was just thinking, we are here. We've gotten caps, T-shirts, conference in a nice hotel. Okay. The person, the VHT, who is finding the person with TB? No cap, no T-shirt. Maybe we collect these in a basket and send them to the best performing district. Reimagining TB, that's the sort of thing I'm thinking. Because they will give the funds to you because they know your name, you are seasoned in the field. But just like Dr. Mustafa said, if after 100 abstracts and all these things, all we can do is get another grant, maybe we need to reimagine if we're actually going to end TB. So just reimagine, maybe the next conference should be in Karamoja. We stay in the Manyatas. If we're going to reimagine, let's reimagine properly, you know, so that we can say, okay, we have gone there, there is nothing there, let's go back to business as usual. Thank you.
Okay, I think the chairs will have to rule on that, whether we will sit. But can we really respond to this question?
Yeah, I think I will start. And I will start with his issue that probably civil society probably and some other key populations were not represented in this. But I would say definitely some people may not have been represented, but we worked through the Stop TB partnership. And we had 6 civil society organizations that we worked with, who we actually subcontracted or even gave memorandums of understanding, and they helped do the work together, and they were supported. So it was not only one civil society or one group. There were about 6 of them, and we went through Stop TB partnership. But I agree that probably we may not have gone everywhere in the country or visited. We didn't do this work at the lake. And that's why we've even come up with a toolkit to see how do we continue this work later as it works out. Do we have any guiding tools? And this engagement is going to continue. And in a way, answering Moses' question, the engagement is going to continue. As we develop these concepts, finally we are going to say we need to come up with IT solutions for VHTs. Should we just sit down and complete this VHT? We need to involve the VHTs who are going to use either the tablets or the smartphones we shall provide, and make sure that the people have the knowledge, the skills to do it. You have to work with the community to make sure that maybe the VHT who is there does not know even how to use a smartphone, and you are saying you are going to give him a smartphone. So I think this engagement should continue throughout until the processes, and even next week, actually the week after this next week, we've already invited some people from health education to make sure that even as we think of through these concepts and others, the actual engagement of the stakeholder is there. That's why we are even engaging DHIS2. We have already had meetings with DHIS2 to make sure that you develop the electronic case-based surveillance system. If we develop a community digital system, it should talk to it. It should fit within the government. We've already contacted the commissioner, Assistant Commissioner Pombaka, about what are the requirements of this. So we are engaging everybody so that finally the product which comes up is endorsed by everybody. So that engagement will continue, and we shall continue to engage people. So that's what I can say.
So colleagues, join me to give a big round of applause to our panelists here. And thank you. With that, we hand over to Paul.
Thank you.
Number 95, 90, and 0 for you to have lunch. 90 and 0.
Yeah, I have the difficult task of standing between this time and your lunch, especially when the coupons have already been distributed. But we are going to be very short. We are going to take very short time. And Moses Salinaitwe, please come over here. Mr. Omulongo Kato, where are you? Actually, you can even stop there. Can we all stand up? Moses Salinaitwe, give us an energizer to wake us up.
All right, so hands up. We are going to make a T for TB. And now we are going to reach every corner where TB is. So get your right hand and put it over your left scapula. Make sure you can touch it. The scapula is this one here. So just to touch there, okay? And then let your head push back, okay, until you feel something. Then bring back to teeth. We go the same way. Okay? Push back. Right? We are still here in the teeth. Get your right hand, left elbow, pull back. Make sure it touches the shoulder. Opposite. Okay? Like this, hold, pull back. You should feel something popping out. Okay? The other side, hold the right elbow, pull back. Okay? Now let's go down to the waist. And we have been here at central level, let's go to regional level. Right? So I don't spell Karamoja. Okay? Alright? Here we go. A. In capital letters. R. Right? Another A. Okay? M. O. J. A. Okay, now we are going to go to the VHTs, right? Yes, you have to touch the toes. You have to. Okay? Okay, so once we are at the toes, lift the right hand all the way to the top, so that the VHT needs to have direct connection to the funds at global level. Okay? And then the other side also, the VHT has to have access to funds at global level. Thank you very much.
Yeah, thank you, Moses. And I doubt there is anybody who is not awake. You can take your seats. Okay. My name's Dr. Isiko Kawanguzipo. I'm the Executive Director of Uganda's Stop TB Partnership. And we are supposed to be in group work. But from the looks of things, I think we are behind time. Thank you, Professor Joloba, for taking a bit of my time. But it was quite well and okay. So, now, you have been given time to ask questions. Now it's me to ask the questions. So we are now in plenary, and we have had all the discussions, and I think some areas we have been already very well covered. Social protection, I believe we are well covered, isn't it? Okay. Now, the group work, we are supposed to have had 5 groups, and then if you've seen your program book, if you go to page 14, those were the groups we were supposed to have, and they were supposed, 3 of the groups were supposed to be covered by the DHOs, chaired by the DHOs, and group 5 by the hospital directors. Maybe I'll start by even group 5. And if the hospital directors could actually help us. How do we reduce death at national and regional referral hospitals? The questions are to the plenary. Mr. Kato, if you could help me to move the microphone, or another volunteer. So how do we reduce death at national TB death, reducing TB death at national and regional referral hospital? So please just raise up your hand and respond. Anybody? Anybody?
First, from the directors of regional referral hospitals and health workers from regional referral hospitals. Please stand up. Stand up from regional referral hospital. If you are still with us, regional referral hospital, still with us? Where are they seated? You can contribute. Time we don't have, but you'll contribute. Please, kindly, directors. Oh, okay. Okay. Where? Okay.
Yeah, thank you. My name is Dr. Gilbert Aniku. I'm a pediatrician from Arua Regional Referral Hospital, and I'm here also for my director too. So it's been a very enriching discussion on what we need to do about TB. When it comes to an issue of patients dying from TB, I think it should make us reflect beyond. Because what happens at the time of death may not be limited to TB. It is a failure of the body systems at that stage. So the question here should be, to what level are we able to support a person who has TB or any other disease for that matter, who has some of those failing systems? Talk of, in TB, the majority of cases have pulmonary disease. Some of these people will need, as part of supportive care, supplemental oxygen delivered in any of the methods in which it is given, nasal, face masks. Others may be so sick that they need to be in an ICU. So the questions that we need to answer here is, how are we equipped at the regional referral hospitals to be able to offer this support? What is the availability of oxygen and the delivery mechanisms for these patients? How about our ICUs? How many of us, or we could ask those who run the ICU facilities, how many of them are willing or able to take a patient who has TB into such an ICU facility? When COVID came, I think we learned from Dr. Mustafa that COVID was very aggressive. It took off all resources. But when we have a person with TB, how willing are we able to commit to have our ICUs to support such patients? I think I may just limit it to that and give to others. But the other, which I think is important, that we need to pick up and learn from other areas, other program areas. We talked about integration. I told you I'm a pediatrician, and we're passionate about newborn health, newborn deaths. We do perinatal death reviews. We do maternal death reviews. How often do we do TB death reviews? I think that's a question for many of us here, and maybe to lead us to minimizing, if not avoiding the deaths. Thank you very much. That will be a yes, where the oxygen facilities are available, and the method for delivery and others are the same. But we need the oxygen there in the first place. And we have had plants, oxygen plants established in most of the regional referral hospitals, I think. And those newer ones are having plants coming up. The issue around the plants is the servicing challenges which are centralized. And I think that's an area we need to work closer so that we have patient or person-centered care delivery. Thank you very much.
Thank you. Arua Patients need oxygen. Oxygen
Thank
is
you,
in the
Andrew.
hospital. The struggle is whether TB patients can be allowed to get oxygen. You hear that? So someone can die with TB because they need oxygen and it's not there for them. I think that is something that we need to take up as directors. The TB patient is a patient like any other patient. Okay? There are actually people who are in ICUs of private facilities because of TB. But the private facilities don't know. Those are the high-level people who go to those high-end health facilities. So a TB patient can actually be in ICU as well if they need ICU. Hey, the other people sat. Afiz, how do we reduce TB death at your regional referral hospital?
Thank you, Doctor. Yeah, good afternoon, members. Dr. Chibuka Afiz, consultant physician, Jinja General Hospital, but also Deputy Hospital Director, Jinja General Hospital, and probably also clinical head. Now, to this, why people, how would we reduce mortality? From my observation, most of the TB units which I have been to and where I stay, I think one of the issues which is lacking is regular review of this patient by senior colleagues. That's from specialist to consultant, senior consultant. Most of the time, TB ward is left to either enrolled nurses and 1 or 2 clinical officers who suffer with these patients. And I think, without blowing my own drum, hospital where I've been to, I have been on TB wards, and I think there have been a noted decrease in mortality. At least because I was in Mubende, in Jinja, they can testify. At least I go there, and this, what I've seen, because these patients are not reviewed. If you review them, you're able to discuss with the team and work on mortality. Because what kills this patient, but it's not TB, it's comorbidities. Today I was sharing with my colleagues here that I've observed by the patients who are HIV negative, who come with the TB, I like to have bad reactions. They have cavities, even find that sometimes their response is poor compared to even those who have HIV. Because those who have HIV, since we have all these improvement patterns coming in, you find the care is a little bit what? Better. Therefore, I think if as senior colleagues we can visit these units, we can reduce this mortality and guide the young ones. And also the other thing, maybe as hospitals, regional referrals, we can allocate and supervise interns rotating to these units. You find most of these hospitals, interns don't go to TB wards. TB ward is left as if something neglected. I think if we work on that, it will sort out this. Because even when you try to look at the death, the mortality audits, you find the issues. What this patient died, they just said the patient died. But ask them, did you check even a blood sugar? Probably no. Then when somebody is put on oxygen, he can stay on oxygen, SATs reach 95, he's still on oxygen. Therefore, ends up getting what? Oxygen toxicity. Because there is no senior doctor who comes in to guide the team. Therefore, probably if, yeah, of course now me being now deputy director, at least I have to go there, but also we request all other people to really go there and we can sort out this. Yeah, of course the issue of supplies in all regional referral hospitals is the same, and consumables that run short of this. But I see we can work within. Like, for example, oxygen. Because, like, if management really allocates a really key person to that, it has to know that I should have at least 1 or 2 cylinders of oxygen, what? At standby. But you don't need to wait for the patient to come, then start running for oxygen. Therefore, so that one will cause upon also management to stop only allocating the lower cadre. You find most of these TB units are run by, you have an enrolled nurse, then you have nursing assistants, yeah? Then you have 1 or 2 clinical officers. And also when you get maybe a nurse who is interested and a clinician, then later is transferred. Therefore also management plays a role on this bad outcome from these what? Units. Because I know the program takes in a lot of resources to train these people. Therefore if you just transfer them, also it will affect. Lastly but not least, there is stigma, also plays a role. I'll give an example. For example, you have a patient on TB ward. The senior doctor doesn't want to go there because there is TB. Then the junior staff also will see because they copy. If the senior is not coming here, if he has to get TB, why should I go there also at night to check that person's what? Drip or what? Therefore, all that goes through that. I'm sure if we improve on that, as the senior people visiting the units and providing management and supervision, we shall be able to reduce this mortality. Lastly, is of course late reporting. As the regional referral, we don't have control over that. But those who come to us, if we do that, we can be able to change that. Thank you very much, Doctor.
Thank you so much. We shall cap it here for that question.
Okay.
Actions are the hospitals need to do mortality reviews. They need to assign senior people. They need to offer critical care for those who need critical care. Okay. You want to still be on the same? Why don't we move to another one?
It's almost the same. He has provoked me to describe what was on the screen there. To me, it seems it was the senior, or even if it was not the senior medical officer, then he was somebody with a stigma. He had put a stethoscope on the chest, but with the clothes, when the patient was in the dress. So I was wondering whether the cryptation was, which this person was listening, were from the clothes or from the chest. So please, senior doctors, and in fact, this must have been a senior doctor. The stigma he had, just put a stethoscope on the cloth of a patient. So I was in my doubt. The cryptations were from the clothes, not from the chest or from the lungs. Thank you.
Thank you so much.
Thank you, Chair. Yeah, now, okay.
Maybe before you go to the next, for those where people come late, because you are regional centers of excellence, you can support us reaching out to those districts. Yesterday you saw some districts are at case detection of, I think, 20 or less. In such districts, if TB exists, people are likely to come to the regional referral hospital when they're about to die. So if you have such a district that is sending, where people are coming to a regional referral hospital when they're about to die, it means you need to give that district support. Please do prioritize that also as part of management at that level. Over to you.
Okay, thank you very much, Dr. Stavia. And yes, in 2018, we had the UNHLM, the first one on tuberculosis, and we had the targets. We met some we didn't really do very well. And this very year, again, we have new targets. But for now, I'll look at the 2018. And yesterday, Dr. Stavia really elaborated so much about how far we have gone. Now, before I get to diagnosis, treatment, and prevention, and I think that question will be mainly addressed by DHOs, can I have the CSOs to stand up? The CSOs in the room. The CSOs in the room, please. No, I know there are very many. Where are the rest? Okay, I'll still ask the question, and it's related to the UNHLM. Among the targets for 2018, which we didn't do, actually where we did worst, was about financing. So, you as CSOs, you are supposed to help in the mobilization of resources. So can you please be able to, what is your role as CSOs to make sure that we get more funding for tuberculosis? Your hand up and the microphone will find you.
Thank you, Chair. I will respond by saying funding does not only mean cash. First of all, CSO, as partners, we contribute a lot to the docket of care. I think this has been a good practice. The doctors treat and we take over the care. Looking at our community systems in place, there is a lot of support in terms of reaching our clients through home visit, through psychosocial support, through counseling. All that is a lot of funding if you quantify it. But however, we also reach development partners seeking for the same support. And we have been engaged, also reaching partners to support TB as a separate entity as it has been in HIV. Just our support has not been quantifiable, have not been acknowledged by the state because we didn't have a one-stop center of reporting. But by last year, Uganda AIDS Commission has initiated a system where civil society have started reporting. And I believe in the next quarter, we shall be getting our outputs as civil society, what we contribute, and we quantify it in terms
Thank you,
of
Simon.
money.
Thank you, Simon.
Thank you.
I see Moses. Moses, now when you are responding, tell us what you've not done that you'll do better to get more resources.
Thank you, the chair, and my ED is not, I think he's expecting me to say what he was supposed to say. We are so happy with this response. I know there are a lot of things that we have done, but there are still small opportunities that we have learned from the engagement and even from this meeting. I think we are so appreciative of the role of CSOs themselves. The capacity of CSOs is some area that has not been well enhanced in resource mobilization. I know in the country we have supports for CSOs, which has been existing even for HIV, and I know including the implementing partners or mechanisms that are in the country, they have some allocations that support CSOs, but most CSOs have not been well enhanced to access these resources. It is one area that we need to strengthen to build the capacity of CSO in resource mobilization, in writing a winning grant right from local level and at the international level. So we are asking our partners, the development partners in the house, that when you see CSOs applying, you know that they are responding to this call. I think that's what I can say for now.
Thank you, Moses. And I want now to get this to the end. But okay, let me allow Fred on behalf of the TB survivors and the last one to contribute.
Yeah, thank you very much. I'm Fred Bill, the Executive Director of Fellowship of TB Survivors, Uganda. To me, according to the question you've asked, Chair, what I very well know towards maybe the contribution of the resources through TB, I always know that as civil society, we always don't work alone. We normally come in partnership and we coordinate with the local, the international, to at least try to get a way how we can generate funds towards support for TB. Thank you.
Okay, thank you, Fred.
Chair, I think your voices are over. I wanted to add the survivors need to get more voices within the districts. Like this issue we're discussing of mortality, if TB patients are dying because of being neglected. It is the survivors who are going to rise up and speak so that these people can get better care. So we need more voices of these survivors in all the districts to be able to support us in offering them quality services. But also for mobilization of resources. We have the TB Reach Wave 11 out. So as members of the civil society organization, coordinated through the Stop TB partnership, can we put up good write-ups so that we attract a good part of that resource to Uganda? Kindly register your existence with the Stop TB partnership also. Thank you.
Yeah, thank you very much, Dr. Stavia. Okay, yesterday, our keynote, the gentleman who gave us the keynote address, encouraged us to celebrate milestones. And we really celebrated from the presentation that was made by Dr. Stavia. And Professor Joloba gave us a very good presentation about the diagnostics, those which we have and those which are in the pipeline. But still yesterday, among the things that were really came out is that like one district, I think, had 0.1% on utilization of gene expert. So there is a problem somewhere in diagnostics. So the DHOs present, I will not tell you to stand up, but as we celebrate the milestones for diagnosis, treatment, prevention, and care, where are the gaps? We are talking about 90-90-90. Professor Joloba talked about 95-90 and 0. And 0, of course, we shouldn't face, any patient should not face any catastrophic cost. And we know that the DHOs really are the main custodians of health care in the districts. Where are the gaps? How do we get them improved? So please just rise up and the microphone will find you.
Yes.
Thank you. For us, the attitude we have been instilling in our staff is no cough is innocent. And if you don't look for TB, TB will look for you. So the purpose of this is to make sure the staffs do early diagnosis. The early diagnosis means the patients will be stable enough to go through the entire process of TB treatment. Thank you.
My colleague, the one who is on the league table, has said it. But I'm DHO Maracha. Suffices to say that the journey walked by a TB patient from infection to death is a very long one. That's why they are called chronic diseases. Along the way, there are issues in our health systems. Some of them may be at a district or local government level, others at the central level. But limiting ourselves to the district level, to what extent do we have a complete district health team that links up with the rest of the extended district health management team to be able to provide this quality health information that the population needs? That is the first thing to start with, because it needs a team, or it needs somebody in that team to diagnose and tell the rest that, you see, any cough should never be treated as what? Innocent, but guilty. If you do not have somebody or some people in that team to detect that, you have a problem. The second thing is very many technologies will be in place, and the facilities are working. If we do not look back and see what we have done, that is the review meetings. If we do not look back and see what we have done and why some facilities or some local governments have done better than the others, why certain services are not utilized, you will only find them in a national meeting. Maracha district, we also faced the same. I joined there some time back in 2018. I found our case detection rate was 32%. That means we were only detecting 32 out of every 100 expected TB cases. The question I asked with my team members was, is there no TB in Maracha? Or our clinicians don't know how to diagnose TB? Since I did not get the answer, the next comment I made was, if we don't look for TB, we shall be the next TB patients. And it happened. 3 of our officers, health workers, got TB. Or they were diagnosed to have TB. Then the journey started. I think that is what has brought us to this level. The regular reviews and so on made us know that this problem is not only for the patients, but for us. So it is about the systems, but access to information. Patients or community need to know. And that awareness brings them to facilities. The staff should be able to also take good history and therefore refer them to laboratories. That mix of interventions, once we don't do them, I assure you, you will see the picture. Thank you.
Thank you. Okay.
Thank you, Dr. Char D.H.O. Kotido. Let me start by somebody asked about...
Maybe introduce yourself first.
I did. Dr. Char D.H.O. Kotido.
Thank you.
Somebody asked, said the role of TB death audit. We have a hospital called Matany. In our quarterly performance review, they present to us. And one thing they present is a finding from death audit. Most of the causes of death in TB patients are actually preventable, just like maternal death. In our region, alcoholism, I'm not putting in order anyway, alcoholism, smoking, and malnutrition, those 3 are top. So if we do that, we can identify the top causes, maybe per region, per district, and then we can work with the patients to prevent. These are simple, it's not cost, I mean, it doesn't cost much. Then now I go to the gaps. We are here gathered, we are actually delivering fruitfully because we have many brains here. So I'm talking about human resource issues. If you go down there at primary health care level, the lab team are many lab assistants. All these ones, they train on job, I call it microscopists. They are there, but not that people are not there. We have been crying for wage to recruit. Majority of my staff are those lower ones, lab assistants. People have gone to school, we cannot recruit them. Can we advocate for wage to recruit well-qualified cadres? Then 2, infrastructure. There is no proper and direct investment in infrastructure. The lab we are calling labs down there, they are just rooms. Just rooms. You see, you enter a lab, you see a microscope put like this, and no light, no what, everything must go on there. So if we look at, we have been advocating for at least some improvement in lab infrastructure. USAID projects they tell us the donors, what the donor say does not allow, the policy does not allow, but in some places you find they're using such words like remodeling or doing what. So let us also look at that. And then lastly,
Over time, investment in TB has not been significant. It's actually insignificant. Dr. Stavia is basically, one, it is a vertical program by nature and heavily dependent on partners. As government, local government, at lower level, we don't have much funding for TB, save for our partners. So I thank IDI for coming in, but it was a long journey for TB program in Karamoja. Thank you.
Thank you. Yeah, there's another hand. Oh, there are several hands behind there.
Comes the vertical programming. We have said TB should be part of the primary health care package. If you have funding for primary health care, you have funding for TB as well, somehow. Yes. You know, the conference is about financing, innovation. So think. TB should be part and parcel of the primary health care package. Yes, the other donor funding is adding on to what we are doing. But we should make it part and parcel of the general primary health care package. We are ending your sessions shortly, Paul. In 1 minute, please.
Time is not on our side. Maybe just one other person and we end it.
Yeah, thank you. It's from Karamoja also. Thank you very much for your kind consideration. My name is Omoya Dennis Ochula, the DHO Lamo. I am going to focus on prevention. And at grassroots level, we are going to engage in recruiting more stakeholders towards the fight against TB. We'll engage in sensitization, mobilization, and especially working with political leaders. We want to give them information on TB, how to prevent it, and how to support those who are already affected, and let them know that all of us are candidates for TB unless we do something differently. And using the same opportunity, we'll engage them and win their support so that out of the locally raised revenue, we put something small towards TB. And this will support us especially in following up of TB patients and contact tracing. And we'll also work towards mainstreaming TB. Yesterday, this one came out very, very strongly. And the Human Capital Development Program will work very closely with the education team, community team, but also cross over to production. Without feeding, without food, TB will be an issue. We'll let them understand this. Works department, we have heard about infrastructure. We'll work with them to make sure that the design of our structures are TB sensitive. For me, this is how we are going to work going forward. Thank you very much.
Yeah, thank you so much. Time is not our best ally, and we are going to leave it at that. And of course, to me, all the responses were excellent, and you can clap for yourselves. So at this juncture, let me now hand over to Dr. Patrick. Dr. Patrick, please, the floor is yours.
A round of applause. What he has done in the last 1 hour or two has been phenomenal. Please give the panelists and yourselves a round of applause. We started when we had a lot to cover. I was so worried, but looks like we have been able to cover. And now we are getting into the closing session. The idea is that we conclude this now, so that when we move out, we don't have to come back. The only thing we shall be doing is networking, sharing ideas, and anything that we need to add. So the closing session is going to be as brief as possible. And I implore the people who are going to speak to us in this closing session to know that they will be standing between the people and the lunch. If you extend this session, you are not going to be very popular with the people. You know what I mean. The coupons have been served. And also your medical doctors, you know, you could have an emergency if you extend. Some people don't have to take long without taking a meal, and that includes me. So this is what we're going to do. We're going to hear somebody read for us the 2023 communique. We shall also see the awarding certificates of recognition ceremony. We shall have the implementing partner closing remarks. We shall have the chairpersons of DHOs and the LOC5 representative to speak to us, and the closure. And each of these items will take under 5 minutes, if possible. May I, at this juncture, invite Dr. Rose Kengonzi to lead us in reading of the 2023 communique, and after that, the awarding certificate of recognition ceremony will be led by Dr. Stavia. So can we have Dr. Rose Kengonzi come, step forward, and as she comes, ladies and gentlemen, let us welcome her in front here with a round of applause. Dr. Rose. That is morale, you know, they are giving you morale. They know you've been here for quite some time.
So good afternoon. I'm privileged to have been given this opportunity to come up with a summary of what transpired and the actions that we came up with that we think needs to be implemented. And before I start, I have to recognize the people that I worked with. We were Dr. Maureen Sekade, I worked with the Matthias, a business model. The next is prevention and health promotion. And here, what we captured is health promotion department to consider including TB messages in the various approved IEC materials, yes, for dissemination. Then increasing investment in the Live TB free campaign at national, district, and community levels. And then integrating CSOs in mobilization and sensitization to reach key and vulnerable populations. The other thematic area is TB case finding, care, and treatment. And we managed to capture one, decentralizing DRTB treatment initiation at district level, and only patients who need special attention to be admitted in regional referral hospitals. District to prioritize TB and leprosy in planning and implementation. Rapid uptake of new recommended guidance by WHO. Developing a roadmap for introduction of shorter term regimen, especially for PID-TB treatment. And then Ministry of Health, /NTLP, to work with USTP and Iganga District to start the construction of the MDR ward in Iganga District as soon as possible, as more funds are being mobilized. And then all hospitals to conduct mortality audits and ensure access to ICU and oxygen for TB patients like the rest other patients. For system strengthening and coordination, we need to do phased implementation of CAS-TB at district level to improve efficiency, meaningful engagement of the community, including TB and leprosy survivors, and HIV networks, decentralizing capacity building interventions and activities to regions and districts, and strengthening the cross-border interventions like capacity building, laboratory diagnosis, risk communication, and IEC materials. Then implementing partners to procure computers to facilitate utilization of the ECBSS at all DTUs, and it's expected by the end of 2024 we should have 100% coverage of ECBSS utilization at facility level. And then lobby for Ministry of Health to consider upgrading at least one health facility in the Misindwa district to a health center for status to improve health service delivery in the district. Social protection, Ministry of Health to work together to identify the risks and link TB patients to TB-specific social opportunities, social protection opportunities, because the proposed opportunities under Ministry of Gender are TB sensitive but not TB specific. Then we need to engage NSSF on awareness creation on social protection programs and mindset change. And then TB survivors to be supported to improve their socio-economic situation, identifying and linking them to, for example, PDM programs and other income-generating activities. Then for leprosy, we need to implement innovative approaches for early leprosy case detection and treatment, including extended contact tracing and administration of leprosy preventive treatment, especially in West Nile region. Thank you, that's what we captured, and I hope that's what was discussed. If there's anything, it's welcome that we may need us to include. Thank you so much.
Okay. A bigger round of applause for Dr. Rose Kengonzi and the rapporteurs who have been able to capture what we have been up to for the last 2 days. Thank you so much, Dr. Rose. So may I invite, with a lot of respect, Dr. Stavier to lead us in the awarding certificate of recognition ceremony and tell us more who else is going to be here. And as she does that, Dr. Kaziwe, you'll be preparing yourself because you come next to tell us about the implementing partner closing remarks, which will also be very brief. Please let us welcome her with a round of applause.
Thank you, MC. I want to invite, I think, about 3 people to help me in the award of the certificate. Okay. We'll be joined by Honorable Joel Sevkai, but as he comes, I think the Honorable who's there can be awarding on behalf of Honorable
John Paul, I think.
John Paul, you're welcome.
He has a medical background as well.
Yes. I want also to invite Director from the Ministry of Local Government, because we are going to award people from the local government. So we take the opportunity that you are here to award your own for the excellent performance. So we'll start with the best performing districts. And now they know themselves. So you line up and come. Madi Okoro, Maracha, where's the? It's fine. So we want to have these certificates for, where? We want Madi Okoro first. These people are giving me someone else. Yes, so I think they will read the certificate.
Certificate of recognition. This certificate is awarded to Madiokor Best Performing District 2023 for your outstanding contribution to the fight against tuberculosis and leprosy. Ministry of Health encourages you to continue in this fight. Issued on 8th December 2023 at Imperial Resort Beach Hotel, Entebbe.
Okay. Thank you, Madi Okoro. Next is Maracha. The next, Namisi Indra, be coming also. Thank you, Maracha team. We are very, very happy. Please keep it up. It's above 90, and now we have some hundreds also, so keep it up. I don't know that they are seeing all of you properly. Okay, thank you. Now we are in Namisindwa. Thank you. Okay. So, Namisindwa, thank you. Please keep it up. Work harder. Now we are going to Butevo. The team from Butevo district. Yes, thank you. Our colleagues from Butevo, thank you for shining this 2023. Please keep shining. Keep TB on the agenda. Let it be in your plan. Let's eradicate TB from the district. At the IP, I'm sorry. I was going to still be calling people to support me. Terego district. Alex is no longer here. I have not seen him around. Now, Terego, we want you leprosy, zero leprosy. We want zero TB. Yes, you are the highest or highly burdened district of Uganda as far as leprosy is concerned. Best in TB, leprosy, we want zero. We want you to be the best to eradicate leprosy also. Thank you. Manafa? Manafa? I said you know yourselves. You should be lining. you have the report, just look. Now Kabongo should be standing up so that we don't take a lot of time. Thank you, Manafa. Yes, thank you for supporting them. Please keep them on their toes. We want to start declaring some districts TB free, okay? That you repeat. You can see the vibe that is entering now from Kabong. We might even get a dance here from this team. Thank you, Team Kabong. To get a district from Karamoja to be among the best districts in TB, I think is a phenomenal event for us today. Thank you. Yumbe, you are near? And then lastly, we have two more districts, Zombo and Iganga. Thank you so much, Yumbe. You also are good at hosting our refugees, and so you have leprosy. Make sure your VHTs are searching every day. With the largest population in Uganda, but we can end TB in Yumbe. Please do work hard. Zombo? Yes, Zombo, they have a lot of people coming from the other side also, benefiting from our services. And they have the youngest DTLS, I guess. Yeah, you can see Hajat here. Hey! Thank you, Zombo, for the great work. Yes. Now Iganga. Iganga, they don't only want to build an isolation ward, they are showing that they also are looking for TB and keeping it on their agenda, making sure that people who need services get the service. Are you the only one around? He's coming, eh? Oh, he's missing the moment. We shall spare you. We want the DHO to be here. Now we have from Kabong again, Kopoth Health Center 3. Yes, it is some of those efforts by the facilities that make the districts shine. So we want to recognize the health workers. I want to take a picture with the health workers of Kopoth. I want to take the opportunity of who is the in-charge Kopoth. This one in front, eh? I want to grab the picture with her. And I will ask the MC to post it when he goes back to NTV. This one. So I want my picture. After that, Honorable Joel is here. Is going to continue together with us to award. Please take the picture with my health facility in charge from Pokoth, Kabong. Yes. If she gets this one on her social media platform, she will motivate many other health workers that she interacts with. Now you can come here, and I grab this one with you. The next one. Continue, come. You stand there, that side. The DHO Iganga is here. He doesn't want to miss the opportunity to touch the hands of the honorable MPs and the director from the local government. Thank you, Team Iganga. We want to start the ward. Go back and start creating a space where to put the ward. Thank you. The next facility was Bumbo Health Center 3. Now, Bumbo Health Center 3. Bumbo. Bombo, not Bumbo. Boom. It is B-U-M-B-O. Bumbo. Oh, okay. Bumbo Health Center 3. Yes, they are the only health center 3 which are doing also MDR-TB management. Yes, this one. You can. Hey, very soon they want to go to health center 4. There's this gentleman who was talking about cast from Serere. From Serere. Hagwara, Hagwara. Are you near? Are you near? Where are you? From Serere. From Serere. And then we have Bukaru Health Center 3, Burambuli. Anyone from Bukaru? Please come quickly. They are coming to support you from the Teso sub-region. Thank you. Thank you. Yes, and then Bukaru and Aleleke from Abim. Are you here? Yes, Aleleke from Abim. Thank you, thank you, thank you. Uh-huh. Aleleke. Uh-huh. All the way from, yes, Aleleke. A moment. Thank you, Aleleke Health Center. Thank you so much. And now we have recognized all of you, the best performers. Let's use the opportunity to motivate the others also to come here next time. Now I have the honor and pleasure to recognize the gentleman who made a lot of inspiration to us yesterday. Dr. Mustafa Gidado. We are very, very honored that you flew all the way from Nigeria to come and inspire Ugandans about TB. We appreciate. Thank you. So for this, I will not read, I think I will read a few to come and represent the organizers, because you are so many. Some of you are not here. So the first organizer is the chairman organizing committee. We want to recognize you, sir. Thank you. The next one is the vice chair organizing committee. Vice chair organizing committee, please. Vice chair organizing committee. The third one is Miss Queen Ngalambe. The fourth one is Mr. Matanda. The fifth one is Miss Florence Kebirungi. Matanda Michael. Wotwale ebaruwa nebula next time. We shall be on your neck. Thank you. The next one was Queen Ngalambe. The third one is going to be Luis Mwebesa. No certificate for Queen. You just pick any and give, Don't worry. Florence is not here. Luis is going to represent Florence. Let me invite Maureen Seka, the head technical teams. Dr. Yus is not here. Yes, we thank you. Then I want from the smear team. This report you saw is the effort of the smear team. So smear team come and Kamara, where are you? I saw you seated somewhere behind. Are you still around? Okay, Maureen's picture. She is very good in making sure that the content is the best. Thank you. Smear team, take your certificate. Yeah, okay. Smear team, please. We can still use the same, don't worry. And I think the last one is going to go to the Stop TB Partnership. TASO, and who else was from the civil society on the organizing team? Stop TB, TASO. Yes, they did a lot of work in organizing this conference. The IT team, you don't feel bad. Please come for your certificate also. Despite the challenges, you need to be recognized. Just put a certificate, please. Thank you so much. I appreciate all the work that you did in making sure that this conference is a success. No, we shall give them the specific ones after. I think I've... Okay, and yours. Because I'm standing here. Thank you so much. Thank you, the IT team. Go and learn more IT to stop the flickering of the messages and the... Okay, now that is the people who are in communication and messaging who were fighting yesterday, but they have improved today. Thank you. Over to you. I think the certification is over, Chair.
Give them another round of applause. Thank you very much, Dr. Stavia and the team, for having been able to recognize efforts that have been put in, hard work. And thank you to the team, those who have been able to receive certificates.
Can you allow me to take Mary to sign the board? And the picture, people can pick the picture moment. Please, Mary. Raymond, this signing moment here. Where are the people taking the picture? The pen is there. The donors were signing against money. Yes, around here.
That's a very serious activity and commitment with a target and deadline, and the signature is being appended on the board.
Thank you, Mary. We
just
are
like
very
yesterday.
Grateful.
Thank you very much. Thank you, Dr. Stavia and the team, for having been able to recognize hard work, for appreciating the people and the roles they have played. And I thank all those who have received the certificates. Thank you for a job well done, and keep up the good work. May I, at this juncture, invite Dr. Kazibwe for the closing remarks. I think implementing partner closing remarks from the implementing partners. Dr. Kazibwe, let us welcome him with a round of applause.
Colleagues, in the fight against tuberculosis and leprosy, distinguished ladies and gentlemen, all protocol observed, good afternoon. My name is Dr. Kazwe Andrew. I am an internal medicine physician, and this afternoon I have the pleasure to represent my executive director, Dr. Etkoit Bernard Michael from the AIDS Support Organization, TASO. It's exciting to stand before us this afternoon for the 6th TB and Leprosy Stakeholders Conference. And for me, it brings a lot of memories. In 2018, we were at the Golf Course Hotel, and we had the first TB and Leprosy Stakeholders Conference. And I was privileged to be the MC at that time. I know Dr. Ankolo at that time was the chief of party of the USAID Defeat TB activity, and I don't think we had money to hire a professional MC, and clearly we've made a lot of progress. And at that time, a treatment success rate of 85% for tuberculosis seemed very ambitious. But here we are today, talking of 90%, 100%. So I want to invite us to clap hands for ourselves for the great work we've done since then. On my own behalf, before I get into the additional remarks from the ED, I want to say thank you very much to my teachers and mentors in the house. It's a big pleasure to see Dr. Ankolo in the house. It's a big pleasure. Yes. I know for this time round he has to take the back seat and let the colleagues who are now holding the baton to continue the fight. I want to recognize Dr. Katamba Achilis in the house, representing my teachers. Thank you very much for the hard work that we've put in, and to all of us. First, to the government of Uganda that has enabled this environment in which we can focus on a fight against tuberculosis and leprosy, because we could potentially be fighting for our lives in another way. We thank the government of Uganda under the leadership of His Excellency, the President of Uganda. I think he deserves a louder applause than that. And in the same vein, we thank the Minister of Health, who has shown leadership through the different pandemics and also in the TB and leprosy fight. She was with us yesterday, but she's been with us all through the years. And to the Iron Lady, who has steered all of us to keep our eyes focused on the goal. Dr. Turia Westavia, thank you very much. On behalf of the implementing partners, we are privileged to work under your guidance and stewardship, and we know that with your continued leadership, we will surely end TB and achieve zero leprosy in this country. On behalf of the Executive Director of TASO, I also want to convey sincere gratitude to our development partners in the House. For some of us who may not know, TASO is the second principal recipient of the Global Fund Against HIV/AIDS, Tuberculosis and Malaria, where we receive funds for the civil society actors to continue to contribute effectively to the fight against the 3 epidemic-prone diseases. TASO is also a prime recipient of American money through the USAID as the local partner health services prime partner in Acholi and Ankole sub-regions. We are also a recipient of USAID funds through the Infectious Diseases Institute, implementing the local partner health services TB activity. We also receive American funding through our 11 centers of excellence spread across the country. So surely, TASO has many things to thank all of us for, but importantly, our development partners. I want to recognize the presence of Ms. Mary Bogman, the PEPFAR coordinator. Please convey our sincere gratitude to the American people for all the support provided towards the fight against tuberculosis, but more importantly, trusting TASO to support the rest of the partners to continue to contribute effectively. In addition, I also want to say thank you to Dr. Seyum Dejin, the Senior Technical Advisor for Tuberculosis at the USAID. Dr. Seyum, we are honored to benefit from your technical expertise, and I know that a lot of the work that is happening in the country is because of your additional input in our programming, and we acknowledge your support. And now to the Global Fund, to thank all of us who have contributed to the results that we have together witnessed through this two-day conference over the last 3 years of the new funding mechanism 3, or also known as the funding cycle 6. At the time we wrote NFM 3, we didn't have anyone in charge of community TB interventions at the National TB and Leprosy Program. And I remember Dr. Stavia insisting, can we make sure we are providing for community TB interventions? And today we celebrate the CAST campaign, and we are excited to move to NFM4 to implement the CAST Plus and even much more. Thank you very much, Dr. Stavia, and thank you very much all colleagues who have contributed to implementation of Cycle 6 that has given us the results that we see today. And I know we are now all anxious to start Cycle 7 of implementation. So from my executive director, this is to update the House that we are currently evaluating the sub and sub-sub recipients, 18 of them, of whom the Uganda Stop TB Partnership is among. Dr. Isiko Paul Kawanga. I think he also deserves a big applause. Yes, he is the executive director of the Uganda Stop TB Partnership, but we also know that Uganda Stop TB Partnership is the secretariat of the TB constituency, and so he does a lot of work with his team to galvanize civil society efforts around ending tuberculosis. And so right now he's not very comfortable because TASO, with the guidance of the country coordinating mechanism, has engaged an external audit firm, KPMG, to evaluate the existing SRRs and SSRs. And we hope that when the KPMG team present their report at the beginning of next year, USTP will have passed the mark so that we can continue. It's not within my mandate, Dr. Paul, to... Yes, we look forward to the report, and we expect that at the beginning of next year, and it will set the ball rolling for the engagement of new sub-recipients or continuation of those that we are currently working with, and to also continue the fight against tuberculosis and leprosy. So as we get prepared for the next lap, there have been questions on what should be the role of civil society in ending TB, and we were energized yesterday by Dr. Gidado Mustafa. Thank you very much for coming to Uganda and sharing those very important lessons. Let's remember that we should stop agonizing and organize ourselves, and let's also remember that the work that we are doing is a privilege. So because of that, we need to serve with honor, and let's invest in building our capacity as civil society, as individuals, to deliver more impactful interventions. That means we focus more on using data. Let's engage the beneficiaries more so that we have person-centered approaches in our programming. And let's be good stewards of the resources that have been allocated to us. Let's be accountable in how we manage the resources, and let's deliver results that have impact on our communities, because together we can achieve a world without tuberculosis and also have zero leprosy cases. For God and my country, for empowered and healthy communities. Thank you very much.
Dr. Kaziwe, thank you very much. A louder applause. Thank you. Thank you very much. You can actually see he's appreciating the work that has been done and recognizing individuals who have worked hard and, of course, who have committed that we have a journey to move 2030 to make sure that tuberculosis is done away with. Okay, can we now welcome the chairperson of DHOs, to come and briefly give also the closing remarks, who will be followed by the LOC 5 for Maracha District. Let us welcome with a round of applause the chairperson of DHOs.
Thank you, Chair. I'm Dr. Diogo Nantam, and I'm privileged to speak on behalf of the DHOs and the frontline health workers whose efforts has made us to come and celebrate what we've been doing for the previous period since we last met. I've been warned that I'm standing between us and our lunch, so allow me to say I recognize protocol, but that said, our honorable members of parliament that are here, we don't take you for granted, because we know that some of these things the Commissioner Stavia is able to say them because you supported her to do what she's doing. The implementing partners and all of us who have been in this field trying to believe that yes, we can, and the TB match, we've been told that it has been here since mankind, but we are saying that it doesn't have to stay here so long as the human race is here. We thank you. To us as DHOs, we know that we've been able to do our roles with the support from the government of Uganda. Many times we've been doing a lot of complaining, but today we want to appreciate that yes, much as there is a lot that we may still need, but the little that we've got, we thank you for supporting us. The Ministry of Health, yes, thank you for providing the leadership. Thank you for guiding us. Much as they are saying we don't agonize, but many times when you sit in a comfortable chair, you may think that everything is okay. But when somebody else says what you think that what it should be needs to be addressed differently, and this has been so because the leadership at Ministry of Health is helping us to focus and view things using the same lenses, such that what we think that is actually the best is the best in the eyes of our recipients of the service that we receive. We know that it's a responsibility of government to offer services to its citizens, but we can't forget that the partners that have come to support the system have also contributed a great deal for us not to be here lamenting, but saying, yes, Uganda, national and beyond, we've been recognized that we're on track to achieve the target of ending the TB epidemic. The director from Ministry of Local Government, we've had a conversation time and again and say whose results are these that we normally discuss at the Ministry of Health performance reviews, and rightly today we appreciate that we recognize your efforts at Ministry of Local Government and the others. Our health workers, some of them, we've seen them here. Others are not here. But we know that the disease of TB, just like when one presenter said, one of us coughed and others wanted to hide under the table. Now you imagine the health workers who are identifying these cases, treating them, and saying that we are curing them. Thank you for not running away from the responsibility, and we can't thank you enough. Yesterday, our inspirational speaker, I don't know whether I'd whispered to the commissioner, to all of us focus on organizing how best we can deliver the service and less of organizing. And this is one of the rare meetings where we are not pointing fingers, but all of us are focusing on how best we can get the result that will make everyone happy in whatever we do. And without running a risk of repeating what others have said, I'm also aware that we were asked to copy the business model. And our chair here, they keep bombarding us with adverts. Yesterday we were having tea and we wondered why Coca-Cola and the sugar factories continue to tell us about sugar, yet we know that there is a lot of consumers. So we are not going to hide away from repeating the messages that yes, we need to organize, we need to be accountable, and we also need to put the communities at the center of whatever we do. Yes, we may be experts in our various fields, but if the frontline health workers and the manager at the subnational levels don't share the vision that the center is having, most likely the implementation may not be in tandem with what is expected of us. With the appreciation that we've had and the promises that we've had from everyone, we are encouraged that the next time we are here, we'll have a list of expanded districts that have greens as opposed to majority that were in red. And for this to happen, we need to have support not only for those who are doing well, but also even those that are not doing well. In fact, yesterday we were seeing and confirming that success normally has very many parents. And as you can see, those who are here, the commission and other members knew exactly what it is that they did differently to change the picture that they found. How we wish that even those that seem not to be doing very well, we need to interrogate the issues such that they are at the back of our hands, and we are able to fix those that are within our reach, and those that seem to be distant. Maybe there is somebody outside there who could make them achievable. With those few remarks, once again, I take this opportunity to thank all of you for supporting the districts, the health facilities, and the communities that we serve. There is a common saying that our patients vote with their feet. So the identification and the cures that we are reporting is an indication that they trust the system where they are going for services. If it wasn't, however much you try to look for them, we would be in a game of hide and seek. With those few remarks, once again, I thank our leaders at Ministry of Health and all of you for God and my country.
The chairperson of DHOs, thank you so much for your words, for the closing remarks. Ladies and gentlemen, let us now invite, with a round of applause here in front, the LOC5 chairperson for Maracha. And sir, we want to thank you for your leadership, for all that you have achieved in the fight against tuberculosis. Your district and yourself have been an example, and so let us listen to you giving us the closing remarks.
Thank you. The distinguished officials from Ministry of Health, representatives of development partners, local government leaders present, civil society organization representatives present, implementing partners, the media fraternity, ladies and gentlemen, good evening to you all. I'm Obitre Stephen, the district chairman, Maracha. It is a pleasure for me to make closing remarks on behalf of the local governments of Uganda. I want to start by appreciating His Excellency, the President of the Republic of Uganda, for creating conducive environment that has enabled meaningful collaboration and partnership with our development partners. We local governments appreciate development partners so much for really supporting those various programs in health service delivery. We know we will not have gone this far if it had not been for your support. As you all know, the country has all those various conflicting priorities that require to be funded. So we really once again appreciate you very, very much for that. I want to also appreciate the Ministry of Health for organizing this enriching engagement. We local government leaders, we've really benefited a lot from this engagement, especially when we joined the team in the MAF breakfast meeting up. We were able to acknowledge the collaborative approach of fighting this vice, of working hard to ensure TB is eliminated by 2030. We pray that you continue with that collaboration to be able to enable the country achieve more in the coming year. Our civil society organizations, we also want to appreciate you for supporting the country in the area of advocacy. You are really doing a great job, and we local government leaders, we give you credit for that. Our development partners, we cannot underrate your implementing partners, rather, we cannot underrate your support. You really do a lot on the ground there in the local governments. We pledge to continue to support you in your work and ensure you achieve more than what you have achieved. On our part as local government, we made a commitment yesterday to sustain the achievements already made. And we also promise to continue to collaborate with implementing partners to ensure we achieve more in the coming year. As we conclude this engagement, we local governments would like to request the government to note the following. One, we are requesting the government to really increase funding to local governments to be able to do more than what is done as per now. The second contentious area is the area of human resource. You will realize local governments are really grumbling a lot with human resource. And if you go deeper, you will realize that some of those underperforming districts are badly hit by human resource, inadequacy of human resource, not critical staff. We therefore want to appeal to ministries of finance, public service, and maybe local government to fast track payroll cleaning, payroll audit and cleaning, and mobilize more wage to be able to have requisite staff on the ground in the local governments. Otherwise, without staff, it will be very, very difficult for us to see those underperforming districts to come up. Thirdly, we are really pushing for timely delivery of medicines and supplies. We realize on the ground, at times some of our clients get demoralized when they fail to get medicines and medicines in health facilities. Not only medicines for treating TB and other chronic diseases. Generally, when there are no medicines in health facilities, people, they get discouraged. They keep shunning to go to seek for health care. So we really advocate that medicines delivery should be timely done. Second and last, the issue of coordinating partners. We are saying there should be more effective coordination of partners to make resources more available to local government. There is the issue of equity. On the ground there, some local governments are blessed with more partners than others. You'll really realize others are really grumbling with this fight on themselves. So we pray that there should be more effective coordination of partners in the local governments. We are also saying this kind of dissemination of results, if it could be done more frequently. If you wait for a whole year to disseminate this, I think somewhere, somehow, some local governments will lose track. We're saying if this could be done quarterly, not really involving all these categories of persons, at least involving key technical officers like DHOs and focal persons at district, at lower local governments, to be able to fast track, to be able to see how they are performing and see if they can be able to, improve. And lastly, there's a need to really have deliberate effort to strengthen support supervision to underperforming local governments. As a local governments, we would like to move together. If we see our colleagues stuck, if we see other local governments stuck in this burden, we equally feel bad. We really need to move together. So we really pray if Ministry of Health and partners and implementing partners can really be able to strengthen support supervision to see those local governments coming out of the positions they are in. Whereas a lot has been discussed about TB. I was happy to hear something about leprosy in one of the concluding remarks. Leprosy in West Nile is still high. There's a really need, leprosy cases, there's still a need to really mobilize the resources to really attack leprosy as we attack HIV and TB in our districts. As I end, I really want to appreciate Ministry of Health once again, together with the partners, and pray that we continue with this collaboration. As our time is already against us, I do not want really to move on and on. I want to wish journey masses to everybody, to wherever you are going. We meet next time for God and my country.
Maracha District Chairperson, thank you so much. And representing the local governments of Uganda, thank you very much. The next item, I don't think I have the authority to invite the Honorable Member of Parliament who is supposed to talk last. So allow me to invite you again, Dr. Stavia Tuyahabwe. But as you come also, let us recognize and appreciate Dr. Stavia because she's put in a lot of time, a lot of energy, I can imagine. Putting together a conference of this magnitude takes a lot. But also as Assistant Commissioner, a lot is being done. And it appears from where I'm standing that this is a success. Together with the people you are leading and your team, thank you for your leadership and thank you for your commitment. And I hope this team here and the others will be able to work with you and others so that we can realize the goals you have set. And I thank you for those who gave me the opportunity to stand before you. And I'm looking forward, I'll be keeping tabs to know that we are making efforts in the goals and you have set forward. So please, I give the opportunity to speak so that maybe you can also give the parting remark and maybe give an idea to Honorable Sebikali who is speaking to us. Thank you very much.
Thank you so much, our MC for the 2 days. We appreciate any person who comes to TB never leaves. I know Kamara in his talk shows will be saying something about TB and leprosy. Thank you for associating with TB. I want to observe all protocol. The time is not on our side, but I appreciate all of you. And for the purpose for which I am here, Honorable Joel, we came here yesterday mainly to see how we re-energize ourselves to be able to take on, one, the 2023 UNHRM targets, but also reach the NTB targets come 2030. So we discussed our report. I hope we have all copies now. We looked at the targets and made commitments. You have not signed, by the way. Wow. I forgot. So before you start speaking, you'll first append your signature, I think. As the chair of the National Parliamentary Caucus on Tuberculosis, your political and other will must be expressed on that board. We also have shared most of today the key innovations that are available that can make us reach the end. And we also looked at our midterm review findings. We had an external review of the current strategic plan, and we summarized the key findings in our discussions since we started. We, I think, have been able to deliver what brought us here. So I want to thank you all and congratulate you. As you can see, the people are still here. It is past 4, but they're still with us. It's a sign of commitment. I cannot take this for granted from all of you. I want to say thank you from the deepest part of my heart. Thank you so much for keeping with us. For those of us who are not able to keep with us up to the end, we still appreciate whatever effort you put in. In the morning, the people from the districts were telling us, why isn't the 0.1% that we have mainstreamed for HIV also addressing TB? And we all agreed that that should be the position. And we are going to request from the Minister of Health as guided that that happens. Then from the local government, I've taken note of your requests. The dissemination like we have here cannot happen more frequently, but there are opportunities within the local government. So I want to bring this back to you that when you go and you're organizing district performance reviews, let the districts, the DHOs, prepare for you what is happening within your district so that you can comprehensively discuss. That happens every quarter. So at the implementation level, we can review our performance every quarter. At national level, we do look at this data, but we don't reach every district. Maybe what I request from my team is that when we summarize, we can have simple messages that districts can pick from what the data is telling us as far as reaching these targets is concerned. I promise that we'll focus our supervision on the worst performing districts. So I want to work with you, the partners that are supporting these districts, that next year when we come here, we don't see the same districts in this status. So we shall provide the necessary technical and supervisory role as ministry to ensure that we support these districts to improve from where they are. With that, Honorable Joel Sevikaya, these people know that I appreciate the support, although I keep asking for more. And just today, I was promised by the PEPFAR coordinator that there may be something more coming. And for me there, I clap my hands, I jump around, because it is a TB HIV country and we must move together. So we want to say thank you for those other opportunities that are coming. I want to invite you to come and address our dear delegates that represented so many stakeholders in this country. We couldn't have all of them. I don't know the people in line, how many there are that are still there. We appreciate them as well. We had so many people represented here, from the local governments to the civil society organization, the donors, the ministry, and the TB survivors. We had a very nice skit from them. How I wish we can further empower them to even be more vibrant. We appreciate your work. Thank you. And I wanted to wish you a Merry Christmas. I think it is befitting. I also wanted to wish them a happy 2024 for God and the country.
Thank you, Dr. Stavia, our acting commissioner. But I think as we go back at Parliament, my fellow members of Parliament, Honorable Dr. Ninkushima Jonipo from Ibanda, and Honorable Nanyondo Veronica from Bukoma Simbi District, we should ask the PS why Dr. Stavia has served as an acting commissioner for all these years. There are many years. Are you still acting? No. You are no longer acting?
A substantive assistant commissioner for TB.
Thank you. I thought you...
Unless you want to promote me to commissioner or
no.
permanent secretary.
That is enough. It's what I wanted. Because the other time, your address was acting commissioner. So it wasn't coming. Our moderator, I know you as Mr. Kamara, from NTV. You've done us well. Thank you very much. I'll not go into protocol. I respect each and every one who is within this room. I'm Sevikali Joel MP Ntwetwe, Chankwanzi District. I'm the chairperson of the forum at Parliament, and we were told to come with I was told to come with 2 MPs. Otherwise, if I'm told to come with 50, I can make it. So next time, Dr. Stavia, Dr. Isiko, and the organizers kindly call a big number. Members, it is too late. I'm sorry I misbehaved with my colleague and went for lunch before you. But we are very sorry, and we really apologize for that. But if you can sit within this room up to this time without even shaking, even complaining, then you can clap for your hearts. Thank you very much. Thank you. The zeal you have, kindly keep it up, not until we end TB in 2030. Fighting TB, it shouldn't be a one-man's approach. It should be multi-sectoral. I was telling my commissioner, Dr. Stavia, that we need more sectors brought on board. For example, we have Ministry of Housing, is it housing planning and what? Those things. And when you look at TB and the way it affects people, even ventilation is among the things that do increase the TB spread. So our houses in Katwe, our houses in Katanga, and elsewhere in the country, the ministry must look at them and give proper plans so that people can live with those houses in houses that are befitting. We are members of parliament. What I can share with you, we come from different backgrounds. Others are medics, social workers, lawyers, engineers, name it all. But when we go to parliament, we have 1 week orientation exercise and another week in Chankwanzi. In Chankwanzi, it is totally political. But most of the information, most of the capacity that we get it from civil society organization. And NTLP and our government institutions like Agenda and the rest make sure that whenever you do things, you know, medics have a tendency, those old medics, I saw Professor Joroba, we were trained by him when we were in medical school. But those days, health issues could be dealt with health professionals. But now things have changed, that every person is a participant in health promotion and education. So kindly, civil society organization, engage them heavily, Dr. Stavia, heavily, so that we achieve what we want. When you are doing all this, know that Uganda is one country that has the highest out-of-pocket in East Africa. 41% of the household income annually is given to cater for medical services in families. And that one has kept our people in poverty that they will never move out of. So, as you go and talk about national health insurance establishment, so that our people, the money they are using to cater for medical bills, to mortgage their land, to sell off their hens, goats, there are few who have cows, that money can be used for development purposes in our families. even education. So members, it is high time we introduced national health insurance so that our people can get saved. We are talking about information flow. You people who are within this room, you know it all. You know how TB is spread and how it is prevented. But when you go to Napak, deep, people do not know. When you go to Chankwan's, deep, people do not know. That's why whenever they get any challenge, cough and the rest, they think about witchcraft. They go within 3 months, they're in witchcraft. Another 1 month, they have come to the medical wing, but when their funds are fully exhausted, who is going to take the information there? It's when we have introduced national health insurance, and we have VHTs all choose, if I may say, the way our minister, our great minister wants it, choose that are paid, who can take this information faithfully to the grassroots. So members, it is not a joke. The answer to do is to have national health insurance. I know it is in high gear, my committee members are here, but we should expedite it. Otherwise, thank you very much. I cannot go without thanking Dr. Stavia. We are here because of you. Thank you very much, and your team, Minister of Health, our civil society organization, our PEPUFA representative, thank you, and thank you. Everyone within this room, thank you very much. I'm very proud. I'm at Parliament, but without you, I cannot deliver. As a forum, we have developed a talking tool for members of Parliament. Recently, we were in Masaka trying to synchronize it. On 16th, we shall go back and see. Dr. Isiko is here. We are almost concluding, but we have booked an appointment with the Speaker, the Right Honourable Speaker, Anita Among, so that she appends a signature, and then it is allowed to be used by our members of Parliament. But we thank you very much. The funds we are using are from Ministry of Health, are from NTLP, are from civil society organization. Thank you very much. May God bless you. I think I've talked too much. Why can't I say, for God and my country, and a Merry Christmas? Thank you.
Thank you very much. Another round of applause. Now that the Honourable Member of Parliament has officially closed the conference, we want to thank you so much. And ladies and gentlemen, lunch has been ready for the last maybe 2 or 3 hours. It is time to network, know each other. They say your network is your net worth. And by the way, I've also told after lunch, even the evening tea is ready in the gardens. So you guys, double. So immediately after lunch, you go for the evening tea. Please don't leave the evening tea for the people. Also remember, civil society organization have an exhibition there at the reception. You can have a conversation with Equity Bank. Equity Bank is in the house, and get to know, because it's a partner, or even get an account within a few seconds with Equity Bank. Thank you very much. Merry Christmas, and wish you a prosperous 2024.